Okay, how is everybody doing? Hello, hello, my name is Dr. Lianne. For those who do not know me, I've been teaching the Plab for now a year, and I decided let me open up a week of free sessions, free mocks, just to touch base with all of you who are preparing for the Plab. Some of you have done the exam, some of you are waiting for the results. Unfortunately, not many people have passed in the last batch of doctors who did the Plab exams. And so I felt it was about time for me to just come back and do a bit of more teaching and gathering your thoughts together on how to manage this exam. Yes, you're welcome, you're welcome. Hello guys. So let me just minimize this. I usually start, I'm very punctual. And I try to keep us, within the time limit. So today, what will we do? We'll do a lot. I'll try and cram as much as I can in 1 hour, maybe 1.5 hours if my consultant doesn't bother me in the meantime. Okay. So I want to tell you the role of the junior doctor, because maybe many of you do not know the role of the junior doctor, and you're coming into an exam that is really assessing this. Okay, there are some very good teachers out there. I really appreciate all these academies who have, tried their level best. But you want to also get a teacher who is current, who is keeping current with the exam, who's keeping current with what is going on in the NHS. And it's also your duty to research. So you can't blame your academy, you can't blame your teacher for not teaching you. You also have to take the initiative and go and look up the nice guidelines. You have to go in to the NHS website, find out. I can't believe it, even now when I'm doing my mocks, some people haven't yet known about the COVID-19. It is bound to be brought in this exam. You have to look into it. What are the trends right now in the UK hospitals? Meningitis is something that we still haven't eradicated, especially in children. So you have to know your vaccinations, you have to know your lab work. Don't depend on people to teach you everything. Also take the initiative. But today I thought it might be good to just go over this role of the junior doctor. Let me put myself all the way up here, and then we can talk about some complicated cases, because being an international doctor, one of the things that we have not been exposed to is the different type of patient. For example, maybe the transgender patient, and it may be a bit unfair for you to be tested on a situation that you've never been exposed to. So it's our duty as teachers, and for those teachers who are joining, you're welcome. You're welcome to go in and research and find out more information that we can give our international pool of doctors that are coming in for the WAST, for the Plab too. Let's help them, let's educate them. Don't build scripts in their minds, but teach them to be more independent. This is what I usually do in my classes, okay? And of course, this session, I'm not here to discuss any Plab stations or do all that stuff. I'm teaching you common cases in the NHS. What we see in our day-to-day activities as doctors, in the GP, in the GUM, okay, if you're in psychiatry. So I'm going to try and help you with a little bit of information so that you can apply this not only to the Plab, but to the WAST, to the OSCE exams, okay? And even for your life as a junior doctor, because I don't want you to be too stranded. In this exam, you have to be different, absolutely. Some people pass after studying for 6 months. Others walk in, they come through the airport, they go to the exam, they pass. Some doctors use ICE, in their history taking. For example, they ask the patient, what are your ideas? What are your concerns? Do you have any expectations? It has worked for them. What works for you? The best doctor you can be is your own person, because you don't want to sound like everybody else. You don't want to be robotic, okay? So even when I teach, I say dare to be different. Aim for the highest scores. The maximum points you can get in this exam is 212. Wow. Have we had somebody get to that height? We have gotten a couple of 170s, and it's a bit strange because doctors are supposed to be a bit smart, Why is this exam a bit of a challenge? I believe it's because people don't know what is expected of them. So I'll do my best for you. Okay, and then I'll give you my numbers, I'll give you my websites in the end. Reach out to me, of course, give me time to answer, because I'm trying to balance a job, a life, and the Plab also. And for all those, again, all those who are really supporting, the doctors who have passed and are coming back to help others, I really applaud you. We need very many teachers. So if you pass this exam, help somebody, make a session, make a free Zoom session. Okay, help people. Another thing, guys, please, as I'm talking, just make sure that your microphones are muted so it doesn't interrupt the class. Okay, so the Plab 2 summaries. There are many of you who are from Plab 1, you don't know the idea of the Plab 2. 3.5 hours exam. You should build up the stamina to take 18 stations. Okay, I would practice with my companion for this exam, back to back, almost 36 stations. No water drinking, no breaks, no bathroom breaks. You want to build up your stamina to be able to handle a patient. One patient is sad, the next patient is happy, another one is crying. All these different emotions happen during the exam. Somebody's microphone is off. Okay, let me just make sure that we are all in the same place. Yes. And some of you whose microphones are off, you're my friends, I know you. So don't unmute your microphones, okay? Anyway, so 3.5 hours. Why is your first 18 station on the day of the exam? This is a disservice to yourself, my friends. Okay, and for those of you who don't have money to go to an academy or to pay for an 18 station mock, just get a friend. Today do 10 stations, tomorrow give them 10. The next day push it for 15. Then the next day you give 18. Then push it for 20. Back to back to back, rigorous stations. Don't be spoon-fed, okay? Practice with 6 minutes. You want to practice like you're going for a marathon, so that when you're on station number 10 and everybody in the exam is tired, you're happy, you're strong. Okay, the exam was not fatiguing for me because I had rigorously practiced. So practice, practice, practice. If you don't have partners, practice with your mirror. Try and record yourself. Do what you can. There are very many groups, join them. There are many teachers, find them. Okay, 2 minutes for the question outside, 8 minutes inside. A good doctor knows how to manage their time. You cannot be asking data collection in the last 2 minutes. This is precious time for you to manage the case. Okay? And people say the ending doesn't matter. No, the ending is better than the beginning. How you end something is better. Many people struggle in life and they start off, in poverty, in struggle, and they end up well. It's the ending that matters. So stop wasting your last 2 minutes and just, leaving the case like that. Okay, I'm done. Let me go. I'm done. No, I want you to start your station well, very strong, because first impression matters. How can you forget your own name? How can you forget where you are? These are such important points. Okay, remember where you are so that you can fix your mind in how does a psychiatrist think? How does an emergency doctor think? How does a pediatrician think? Does a pediatrician ask for sexual history? Why do you need that? Okay, does a psychiatrist get into details of sexual history and safe sex? Be very careful because people are losing the focus of the exam. A patient comes in our hospital and they've been referred for anorexia by a GP. Why wouldn't you check if this is maybe cancer? Okay, it could be hyperthyroidism. Okay, what are their symptoms? Not everybody needs to be sent to the eating disorder clinic, especially a minor who is losing weight and they're having symptoms. I want to make sure they don't have diabetes. Why are you treating minors without their parents being there? You have to ask, isn't it strange to you to go into a room or a cubicle and it's a 14-year-old child by themselves? The first thing you want to find out, where is mommy? Where's daddy? How did you get here? How did you know about us? What's going on? Doctor, I want maybe some pills to prevent pregnancy. Poor child, she's scared. So you can't be a doctor. You have to try and balance big sister, big brother, auntie, uncle. You want to find out, how did you get here? It's during the day. It's on a Monday at 9 o'clock in the morning. Aren't you supposed to be in school, Samantha? And this is the part of the social aspect of medicine. You already have been called a doctor. Where is your humanity? Okay, you never start a station with Maftosa. What medical conditions do you have? Are you having any allergies, any family history, all this? No. Can you find out how their day was? On my day, it snowed. So everybody got asked the question. Interesting, it snowed in Manchester today. How did you get here? You have to be careful. It's quite slippery outside. Why? Because it's being human. So don't use your first 1 minute with Maftosa. I have to do my physical. Of course, if it's an emergency case, then you have to adapt. Okay? Let me stay on track because I have a lot to discuss with you guys today. I'm sick and tired of people failing the Plab. It's an easy exam. Why are people failing is because they are very scripted, very rigid. Okay, you cannot rely on me and what I have seen in my exam and I come and tell you, I had a patient who was, I did not give antibiotics, so don't give antibiotics. That's useless information. Why would you follow my approach? You have no idea what happened in the station. So some people are coming and saying, don't offer antibiotics to this patient, don't offer x-ray, don't offer a sick note. You have to go in and find out. What if this woman's leg is injured? Have you done an assessment? You know, somebody has fallen down at work. Did she hit her head? Was a CT scan done? Was an x-ray done? Fine, it could be normal, but you need to be safe and do an examination. Have the woman walk around. Can I see how you're walking? You know, let me even do an exam and see if it's the area is red. Surprise, surprise, some of these cases need a sick note. Some of these cases need antibiotics. You know, when I was practicing for my Plab too, I was told never offer somebody an x-ray for the leg because of radiation poisoning. And in my examination, I asked the patient, how many times have you had an x-ray? I've never had an x-ray, doctor. So how can I say radiation poisoning? Okay, you guys have to start thinking. I offered the x-ray. I got a clean points, clean 12. Why? Because in that situation, what is the patient saying? How are they presenting themselves? Okay? And I'll talk about transgender medicine because it's a whole entity of itself. We cannot isolate people and say, this is a transgender patient. This is the lesbian or the gay guy. These are humans. Regardless of their sexuality, you have to offer them proper care. Not every transgender patient needs a psychiatric eval. What is wrong with you? Some of them are even happier than heterosexuals. So it's odd when you go to a patient and they tell you, I'm in the process of changing from a man to a woman. Oh, how does this make you feel? How is your mood? Are you sad? You need to stop that. It shows you have a bias. And you never want anybody to be biased against you because of your color, your gender, your religion. Most of us have different, well, I'm black. Others are Muslims. Others wear hijabs. You never want anybody to isolate you from what identifies you. So stop isolating transgender patients. Okay, anyways, let's go back. What are we testing in this exam? Data gathering, clinical management, interpersonal skills, meaning you have to gather data in every station. Whether it's breaking bad news, whether it's counseling, you have to gather some information. Whether it's somebody who's coming to a hospital, it happens to us. They come to the emergency room. Doctor, my mother has been brought in by ambulance. Can you please tell me what's going on? You have to find out, who are you? What's your relationship with the patient? I'm very sorry. Did you come by yourself? Okay, let's sit down. Let me talk to you about what's going on. Before I tell you what's going on with your mother, maybe she has a AAA or she has an intracranial hemorrhage, can I get a few more details about the life of your mother? What diseases has this woman been going through? Data. You have to gather a little bit. And sometimes you may not gather the data in the beginning. You may have to switch. So if somebody comes and says, give me my lab work, you want to say, okay, it is usually in your best interest. It's usually in your best interest for me to know what is going on, for us to draw a clear picture so that when I explain the results to you, you will be able to understand them. Attempt to negotiate. But if they say 2 times, I want my results, you have to say, okay, I'll let you know the results and then I can ask you some questions later. Gather the data, guys, okay? What is this interpersonal skills? Interpersonal skills is they just want to see how you respond to people who are suffering, how you respond to people who are having a hard time. Not everybody needs to be told, I'm sorry. Doctor, I have a headache. Oh, I'm sorry. How is this making you feel? That's fake. You have to, and that's why I love teaching the Plab, because I'm able to pick up all these little mistakes. You can't say, I'm sorry in 2 seconds. Listen to some information first, okay? This question, how are you coping with your disease? If the headache started 2 hours ago, how are it's short term, it's acute. So the question of how are you coping does not apply, okay? You can't just hear somebody has a headache and then say, how are you coping? Is this influencing your day-to-day activity? I can see you are very, very discouraged. I can see you are very, what are you seeing? Sometimes people are saying, I can see you're angry, and the patient is like, I'm not angry. Okay, so I'll teach you a few of these points, and of course we can't do a 10-day course in 1 hour. I'll do my best, and I talk very fast, and this session is recorded also, because I guess that some people have not been able to sign on to the class. Yes, they're already asking me, please do a recording, because I'm working. Anyways, listen to me. Here's the thing. Let me just make sure that some of these people can log on to the class. I'll record it and I'll put it on YouTube. So if you need to go, that's fine. Now, what are they here? Interpersonal skills. Back to that point. They want to see how you're relating to the patient from when you get in the room. Okay. Now, before, without all this COVID-19, it was fine to shake people's hands. Now, would I be hesitant about it? Yes, I would, because we are in a pandemic. So it might not be good to offer the shaking of the hands. After the pandemic, would you want to try? Yes, that's fine. Another thing here, clinical management. How are you managing what you have had? The patient has a headache. Why would you offer them neurology first before offering them pain management? Okay. Does every single patient who has a stroke or a TIA, do they have to be sent to the TIA clinic? A clinic is second line treatment. If a patient is having multiple strokes, you have to first stabilize them, and then you can refer to a TIA clinic. Where am I getting my information from? From books, from the CKS guidelines. You can't just offer somebody aspirin without knowing whether this is a hemorrhagic stroke or whether it's an ischemic stroke. You have to do your step-by-step approach. Okay. Anyways, what is tested in the Plab 2? Everything. So those who are doing the exam and coming and saying there's no emergency case, I shake my head and I say, why are you misleading people? As long as it is appearing in the hospital, it is fair game. Pediatrics, OBGYN, neurology, psychiatry, you have to think of new cases all the time. It happens, okay? What are they grading? Consultation, and watch my YouTube videos, because I've talked about this in these videos honestly, in like 3 hours of good stuff. Go watch them. Consultation starts from the beginning. If you walk in a room and a patient is at the door saying, doctor, help me, you have to say, please just give me 1 minute. Let me talk to the consultant. I'll be right back. Because you have to introduce yourself. They have to take your GMC number. Okay. And then go to the patient and say, thank you for being patient. What is going on? Help me. Okay. Are you not feeling well? Do you have a headache? You have to think, am I in the emergency room? How do emergency room doctors act? How can you give a diagnosis without even saying you'll do an examination or checking lab work? Are you listening to what the patient is saying? I trap so many people in my mock because I say crazy things like, I've been taking ibuprofen 600 milligrams every hour. And the doctor says, oh, okay, is it working? Didn't you hear me say I take it every hour, 600 milligrams? That's a red flag. So when you go into a station, be clear-minded so that you can be able to hear what the patient is saying. Okay, so now people are saying there's the old Plab 2 and there's the new Plab 2. I think the Plab 2 is the same. Now they're being a little bit strict because I guess they are realizing many people are coming in that are scripted. How can 20 doctors back to back refuse to give a patient antibiotics and they have a sore throat? And none of them checks vital signs. None of them wants to do an inspection of the throat. None of them wants to do a lymphadenopathy exam. That is dangerous. If it was my country, I would make the laws a little bit strict because it's showing we are just getting information from other people who've done the exam and then we're just trying to replicate it, cut and paste. Okay, you can't do that. What is happening in your situation? Now, the old exam used to be just, they'd give more information. They'd say, patient is Samantha Jones, maybe 50 years old, has come in with a headache. And they do the same thing for the WAST exam. Okay. And and they give you some information of past medical history, vital signs. Now you can get a simple question. 50-year-old has presented to the emergency room. Assess the patient. Is this what happens in real life? Yes. You're just called, hey, Lianne, can you go see the patient in room 12? I'll go and see the patient, and I have to rely on good history-taking skills, good managerial skills, and of course IPS to find out what is going on. Now you must practice with scenarios like this. Okay, don't practice with a station that is full. And how I mean by full is too much information. Have your colleagues just tell you a case. A woman has come into the emergency room and she has complaints. That way you can be very quick with your differentials. You want to be able to at least label 4 differentials for every disease in 15 seconds. How does it come? It comes with practice. So that in the exam, you're not thinking, what are my differentials for back pain? I don't know, stones, maybe, I don't know this, maybe. No, this is the time now to practice. And for those of you whose exams have been cancelled, it's a blessing in disguise. Maybe you need to practice more. Don't stop practicing, okay? So, old exam, simple one-dimensional approach. You ask the questions, you give a diagnosis, you give proper management, you pass. Now, it's a bit multidimensional. A patient can come in and they're having a sore throat and they're having knee pain. You have to adjust to both. Why are they having a knee pain? Is there any relationship with sore throat and knee pain? Could it be autoimmune? Is it different? Is a sore throat just an upper respiratory infection? Is a knee pain from an injury? You have to be able to think in this manner. Even with lab work, let's say a patient has a high LFT, okay, and maybe a high MCV. So it could be it could be two things. The LFTs could be high because of viral infection. They could have just recently gotten immunizations. You have to check. The high MCV could be because of a condition of diet, folic acid, vitamin B12. Are they an alcoholic? So how are these labs related together and how are they separate? I want you to think in this dimension so that when you have a case, for example, a patient has an MCV more than 100, okay, and the ALT level is high. You just don't want to say you're an alcoholic. Okay, that's it. Then this is where you have macrohemoglobin anemia. That's not enough. You want to at least even say, can I do an ultrasound of your liver? Can we do AST levels, GGT levels? Can I do an examination to see if you're having any tenderness in the right upper quadrant? And then now you go to diet. What are the causes of high MCV? Folic acid, vitamin B12 deficiencies. What do they do for a living? Oh, I drive trucks. Are you having tingling in your legs? Yes, I am. He has to stop. Multidimensional. So now you have to think, exercise. Will exercise be a good question to ask in this station? No. Will a travel history be a good question? No. It's not focused. You want to focus on the problem first, okay? So now, to pass this exam, you have to be a great listener. Please. And no more of these excuses. Oh, I went blank. I wasn't paying attention. I called the patient the wrong name. You can't have those excuses anymore. You have to also adapt to yourself. For example, I'll give you a little trick of myself. When I get confused in a station or when I draw blanks, because it happens, we are human, I ask a question. I stop and I say, I've been saying a few things to you, Samantha. Is there anything you would like to ask me at this point? Am I going too fast? Would you want me to repeat anything? Do you need any clarifications? And in the meantime, you're thinking, what do I need to ask? Never go blank in a station. Ask a question instead, okay? So that was the old exam. The new one, you have to adapt, okay? I want you, as you try and practice, and for those of you whose exam is close, of course, say your prayers and go in and just think of it as an ordinary day in the clinic, yeah? Don't stress too much on remembering a script. Think of what is happening in the station and respond appropriately. Those of you who have time, please, can you be up to date with clinical guidelines? Okay, go and learn this COVID-19. What is another current state of the NHS? Workers burnout. All this can be future cases. This is what I teach even in my class. Of course, you have to go above and beyond. And when I teach them, they have to think of getting 150 and above. You're not just reading old stations, but you're thinking of possible new and twisted stations. So you have to keep up to date, okay? You have to expect to do physical examinations. They're not going to tell you, do a physical exam, do vital signs, ask the questions, family history, social. No, they're putting you in a room and seeing, what will this doctor do? You know, if you're in the emergency room and a patient is like this and they're not responding, can you check vital signs, please? You are in emergency. There's a reason why they've put you there. It's not that the patient doesn't want to talk to you. Maybe they're hypotensive. Okay? Patients who are coming in with their family members. Another thing. So if an old woman is coming in with her daughter and the old woman is the patient, how can you not speak to the old woman? You know, of course, the question may say, you know, speak to the daughter and find out why the old woman is concerned or is confused. Why wouldn't you talk to the old woman? You have to. You say, hello, my name is Dr. Lianne, or my name is Dr. X. Is this your mom? Yes, it is. What has been going on? My mom is confused. You have to say, okay, excuse me, let me just talk to her and introduce myself. People are going in and not even concerned about the patient, and they're more concerned about the one who's giving the report. Bad management. You introduce yourself to the woman and say, my name is Dr. X. I can see you're not doing too well. Do you want to lie down on the bed? Can I check some vital signs? In the meantime, I will consult with your daughter and find out what has been going on. Come on, guys, please, please, please. These are just the little things that can make you fail an exam. Another small thing is going into a station and the patient is sitting on the bed fully exposed. It's a breast examination, yes. You've just started the station and they are fully exposed. The breasts are out. Isn't this awkward? Yes. You have to tell her, please, Samantha, do you mind? You can cover up and then later on, I can have you exposed appropriately. And the woman covers up. Instead of talking to her and all the time, you're like, oh gosh, I keep looking below the clavicles. What's going on here? They are just simple things. Exposure. You want to do a pregnancy examination. The pregnant woman is exposed on the table. It's not time for the exam. Tell her, let me just cover you up. And then when it is time for the exam, I'll expose you. Okay, when you're done with a patient, you have to cover them up. If you make this mistake in the hospital and you're doing an examination and a patient is just exposed and you're asking her questions about diet, exercise, you get into trouble. If you leave a patient exposed, you'll get into trouble. So the Plab 2 is not an exam. They are seeing how will you deal with the patients in the NHS. Same thing for the WAST, W-A-S-T. How will you deal with the patient in the real situation? Okay, now here, the safest doctor is one who gathers information, carefully analyzes, based on their medical knowledge, comes up with a plan or management that is effective and safe for the patient. If you don't know a diagnosis, give your differentials, guys. A woman falls down and she collapses. First thing I want to find out, was the floor slippery? Did you feel dizzy? Do you have balance problems? How is your eyesight? How is your gait? Oh, are you limping? What is going on? Why would my first differential be, is everything okay at home? How is your husband? Is he treating you well? You can open up to me, okay? It's strange. Why would you think of abuse as the first thing? Abuse, yes, is a differential, but you want to have it have its place, okay? You may want to ask about cardiac problems. It could have been a stroke. And then in the end, you have such a range of symptoms. She fell down, she was sweating, a bit shortness of breath, maybe she was pale in the face. You don't know what is going on. You have to do your lab work. So I would not even say my diagnosis before I say, let me check your labs. Let me see if you're anemic. Let me see how your kidney, how your liver is doing, okay? Let me at least do some tests. At this point, I want to even invite my consultant. He may recommend a cardiologist. Some conditions of the heart can cause you to have immediate collapse, especially if the valves are not opening well. This is called aortic stenosis. Sometimes collapse can be because of a stroke. I need to do a sample of the head. Somebody wants to talk. Guys, please, you cannot be unmuting your mics, yeah? Thank you. Thank you. I see some people that I know and I'm going to be giving good smiles in the end. Anyways, so do you see, I hope you're understanding what I'm saying, and I'll answer your questions later on. I have a little bit of time today and my consultant hasn't yet called me. That's how you deal with cases you do not know. Give your differentials, okay? You could have a problem with the heart. We may need to put a Holter monitor to check and see if you're having any pauses, okay? We may need to send you for some lab work. Let's make sure everything is okay. It could be a condition of maybe you're dizzy or you're having balance problems or the floor, okay? Please, how can something be Stock-Adams syndrome? Stock-Adams, guys, honestly, leave that diagnosis alone. It doesn't have its place. It is a differential that's given by a cardiologist when a patient is undergoing investigations and they see the sinus. Okay, but not a patient. Okay, guys, come on. You can't be interrupting the course like that. Mute your mics, please. Mute your mics. Yeah. Today I'm working alone, so I have to manage everything. Yeah, mute your mics, please, so that we can move fast and so we don't have to keep interrupting. Okay, there are some cases that are very obvious, like for example, if a patient is having palpitations, of course you want to make sure that it's not anemia. Okay, a woman comes in and she's having palpitations. The three big things: anemia, hyperthyroidism. If she's in her reproductive age and she's having a period, I want to find out if it's heavy flow. This could be the cause. And once you find out that any woman has a heavy flow and painful periods, you can't leave her like that. Send her to the GYN specialist. So that's why I'm saying this, you have to adapt to the new Plab, in that it's not just a straightforward diagnosis. Some people have multiple diseases that are going on, okay? Let me move on. There's still a lot to talk about. Anyways, here's another thing. Mistakes, robotic nature following scripts. I always tell my class, and I call them my dear doctors, you have to go to the GMC and look up common mistakes for Plab examinees. Please go and read and see what they are saying. You should not be asking. You can't be calling people Mr. and Mrs. if they've not told you to call them Mr. and Mrs. Okay, be careful how you're offering confidentiality. Oversimplification of body organs, saying your waterworks. How are your waterworks? What are these waterworks? Nobody uses that. Ask them, are they urinating okay? Are they having any problems with their bowels? Keep the information clear. Okay, your egg producing gland and your veins or vessels. Please. I'll have to you're not muted. I think it's those who are coming in. Dr. ABC, please. You slow down the class if your mic is not muted. Okay, please. And I keep reiterating again, this country and the GMC and the NHS have a duty to protect their patients. They have no idea about your medical background, your skills. All they know is this doctor is going to be having the patient's lives in their hands. Okay, how can they come in and be robotic? It is not safe. So stay away from scripts. Please go back to medical knowledge, okay? If unfortunately you've had a second attempt or a third attempt, before you move on, sit down with somebody, find out, where did I go wrong? Your colleagues, even here in this class, they can help. Sit down with 2-3 doctors and say, can you point out my mistakes? So that if you're going in for a second attempt or a third attempt, you know what you did wrong in the first exam and what not to do again. Okay? Please, please, please be very careful about that. Now, find yourself a good teacher, learn, excel in the exam, and then become a good teacher, okay? Review your past mistakes, go back to real medicine. Where's my Oxford book? I don't have it with me. I think it's maybe at the nurse's station, okay? Oxford Foundation in Medicine. Get yourself a nice book for junior doctors and study it if you have time. This is where you should be getting patient management from. Other things, nice CKS guidelines is a good resource, please. This is what I was telling you about. Listening to what the patient has to say. Go to their website and look, okay? Asking things, don't say everything you tell me will be kept confidential. Can you imagine they are saying this in their website and you do not know? You need to know the battle that you're going into. Okay, you have to be prepared. When I teach my doctors, I always tell them the last 2 minutes should be very special for you. It's not time for you to gather any data. The last 2 minutes is time for you to manage. So I teach this ABCDEFGH of management. I know it's a little bit too long and I like my ABCs anyway, okay? So you've taken care of this patient. You found out maybe they have maybe hyperthyroidism. So in 2 minutes, when that 6-minute bell rings, you want to start thinking, what will I do for this patient? Do they need to be admitted? Do they need a referral? If I'm not sure about them going home or them staying in the hospital, do they need to be kept for observation? Do I need more lab work? So think, A, what do I need to do? Admit to the ward, admit to observation, or away, they can go home. All right? Now, here's the big thing. The role of the junior doctor is all about the blood work, pain management, IV fluids, and antibiotics. So you have to know your IV fluids, you have to know your antibiotics and your doses. You can say we will give you antibiotics according to hospital protocol, but what if the doctor asks you, what antibiotic are you going to give me specifically? You have to know common antibiotics, guys, and dosages. For example, like PID, all right, or even gonorrhea. You need to know ceftriaxone, you need to know azithromycin, doxycycline. You need to know these meds and their dosages. Please, don't take shortcuts. An FY2 in any setting can order full blood count, UNE, urine electrolytes, LFT, RFT, okay, UA, urinalysis, ABGs, random blood glucose, X-rays, CT, MRI, ECG, ultrasound. In any setting. It doesn't, and people like to ask me, do they have ultrasound machines in the GP? Do they have CT, MRI? It doesn't matter. You order it. The nurse will figure out a way of how they're going to get it. Either they'll send them to the local hospital to get a chest X-ray done. After you order it, that's it. Let the rest of the team work out on how they are going to do it. But when you're talking to a patient, you never want to tell them, I'll do an FBC, RBC, RBS, ABG, X-rays, I need to do an ECG. All that is medical language, and you will be flagged for language errors in the exam. Talk about the FBC, like we need to check and see if you have anemia or not. There are a couple of molecules we look up in the blood. I need to check your liver, your kidney function. LFT, RFT, don't use those words. UNE, I need to check your UNE. There are some substances that are broken down in the body that need to be measured. Okay, some of them is urea. It will be important for me to know the levels. Okay, your electrolytes like potassium, sodium levels, I need to find this out. Okay, sometimes we may need to check some scans to give us better detail about what is happening inside the body. Okay, we can do a jelly scan. see if there's any cysts on top of your kidneys. That's the language you use as a junior doctor. Stop using jargon, okay? And the worst thing is to use jargon and then ask the patient, do you know what that means? How do they know what a triple bifemoral bypass is, or a cabbage? Do you know what a coronary artery bypass graft is? They don't. You can assume that they do not know medical jargon, so you have to simplify your language. After you do your work as a junior doctor, then you can get help. Please, and when you come to work in the NHS, don't be that doctor who, after the patient has told you their symptoms, you say, I'm going to get the seniors. So why did they spend 10 minutes with you? At least give them some information. Let me do blood work. Let me manage your pain. Let me start some IV lines. We may need to give you some medications later. Okay? Never say, I'm only a junior doctor. I've not reached the expertise of my seniors, so I don't know what. You can never say that. If the doctor doesn't know, who will know? You need to say things. If you really do not know what is going on in a case, give differentials and then say, I will check with my consultant. I will discuss the case with him. Maybe he can come up with a specific diagnosis of what is happening. Never put yourself down and say, I don't know. I'm going to get the seniors. He's going to tell me whether it's going to be appropriate for you to get a surgery. For example, if a patient comes in and they want to get this small mole removed, or doctor, I have varicose veins, I need to get them removed. You need to find out, are these varicose veins causing problems? Have you done your differentials? It could be intermittent claudication, depending on where you went to school. It could be diabetes. You want to check if there's, let me examine hair distribution. Are your legs shiny? Are the clots large? When you touch them, do they bleed? Have you noticed any ulcers on the legs? If a patient comes and says, I have varicose veins, it doesn't mean anything until you do your assessment. And then what's management for varicose veins? Well, it depends on very many things. For example, I need to see them, okay? If there are some of them that look really large and if we are concerned about clots, I need to do an ultrasound, okay? I may need to do, I may need to also check with my registrar instead of just saying seniors, okay? There are many options for you. Surgery is an option in the NHS if it is not for purposes of appearance. Instead of saying, we cannot do your surgery because it's for cosmetic reasons. How rude. Rude. You can't say that. You know, yes, it's for cosmetic reasons and we know it is, but you can't just shut them down and say, no, we can't do it because it's for cosmetics. No, let me talk to the rest of the team, okay? We can see what we can do about it. As an FY2, what do you want to say to somebody who is saying they have varicose veins? Well, let's see how we can delay the progression. Are you working? Are you standing for long hours? You need to increase the strength of the muscles in the legs because this will increase blood flow. Sometimes mild exercise is important. Give yourself breaks. When you go home, lift your legs up. Safety netting. If there's bleeding, paleness of the legs, distribution of hair is a little bit off. If the legs feel cold, come back to us. You just can't stop a case and say, sorry, we can't help you. No. And there are other options. If we feel that we cannot do this operation under the capacity of the NHS, we can refer you to private surgeons, okay? Or we can look up some private surgeons in the area who can do some, a couple of ligations or whatever they need to do in order to improve their appearance. But you have to be compassionate with her because it's bothering her, okay? Guys, anyways, admit. So you're thinking, if you have questions, guys, just type them in the chat room so I can keep moving. I have, I think, almost 20 slides and we're almost 15 minutes too. So those of you who need to go, I'll say goodbye, but I'll keep going for as long as I can before I'm called by my consultant. Okay. So admission, are they going to be in the hospital or are they going to go home? Blood work and everything to do with blood work. You have to talk about it. Always add pain management, IV fluids, antibiotics. This is what you need to do first before you call your seniors. Talk to the patient about the differentials. It could be this, it could be that. I'll talk to the team and we'll come up with a specific diagnosis for you. What do we need to do now? Every single part of the body has a specialist. You can refer. If it's gastroenterology, you can say we may need to send you to a specialist who deals with intestinal problems. Okay, they may be able to do a scan, or there's a scope that they can use. It goes through the food pipe. They can check if there are any lesions in the stomach or in the upper part of the intestine. This is called an endoscopy. Instead of saying, I'm going to refer you to a gastroenterologist and they're going to do an endoscopy. Do you know what I'm talking about? Are you following me? Do you want me to explain? Have you ever researched? Nobody talks like that to patients. Please refrain from using medical jargon. You're better off explaining it in simpler terms. And sometimes simple language just comes by you thinking, where am I and who am I talking to? And how would I explain it to somebody who is not in the medical field? It will simplify your language, okay? Now, E, emergency 999. If somebody is going home, give them warning signs. You can't give them the whole book of warning signs for a TIA. You don't have time for that. Tell them if you're having headaches, weakness on any side of the body, please call 999. Done. If you're having weakness on the side of the face, if your eye is drooping, if your mouth is drooping and you're drooling, and you have tingling on the hands, and you're having tingling and numbness on the legs, that's too much, okay? Because in the end, when you're doing your last 2 minutes, you always want to make sure that you have a plan, okay? So this is what I'm planning for you, Samantha Jones, okay? We will do this, we will do that. Is this okay with you? All right? Warning signs I want you to come back for. If you're really having a bad headache, it's not been resolved by any pain medications, come back to us. Follow-up visits important. Now here, a patient comes to you and they're worried about meningitis, and then you say, yeah, I don't think you're at risk for meningitis, but I'll give you a leaflet. It's kind of rude. You need to find out a little bit more about meningitis, and I'll talk about meningitis in a few minutes, okay? Do they need a sick note? Give them hope, even though it's a little bit. And how can a doctor give hope? How can a junior doctor give hope? By saying words like, you know what, it may seem that you're in a challenging situation, Samantha, okay? I'll talk to the team. My consultant can give us some good input. We'll get to the bottom of what is going on. We'll do our lab work, okay? If we need to, we'll seek out the advice of a specialist. But for now, let me help you manage your pain. Okay, it seems that the situation you're in is very tough. We are hoping for the best. Okay, we'll do what we need to do in order to make you feel better. Okay, and then you think, if they are going home, what do they need at home? Somebody who is coming in with such bad arthritis, you just want to tell her, if your symptoms persist, call seek medical advice. That's not appropriate. She's going home with contractures. How is she going to be able to cook? How is she going to be able to feed herself, wash her clothes? She may need a home visiting nurse or a carer. Homeless people, when you say, okay, you know, if you have any symptoms, call 999. No, they need a social worker. Some of them you need to ask them, when was the last time you had a meal? People with allergies, they need an allergy bracelet. People with conditions like asthma, epilepsy, diabetes, strokes, they need bracelets. Why? Because in the event of a hypoglycemic reaction and they pass out, somebody will see that their medical bracelet says diabetic, and they won't start giving them CPR, they'll give them some glucose instead. It will save their life. So think of it like that. I know you may have different other ways of doing your management. If you're struggling, I'm here for the ones who are struggling, not for the experts. If you're struggling, you need to have some templates to help you be an organized doctor until you can figure out your way. Okay, hop on my bus. Now this is so important, the setting. Okay, where are you? Who is there in the room? Why are they there? Is there anything you can do for those who are there? And then you can adapt appropriately to each setting. Okay, regular settings in any hospital, you walk in, okay, it's you, the patient, you and your doctor's table, where you're sitting, a little bit of a table there for support with your papers, your pens, your books. The patient is more than their medical history. You want to find out what I call the 3 C's, their complaints, okay, how they are coping, and their concerns. These 3 things you have to ask every patient. What is the complaint? And maybe sometimes they'll just tell you, my complaint is that I have a headache. Okay, their concern could be something different. Their concern is maybe I have a tumor. And how are they coping if it has been a chronic condition? How is it impacting them socially? If it has been chronic, there are things that they love you need to find out about. And 8 minutes is more than enough time to deal with the social part of the patient and the medical part. You do not get full points by just dealing with social part. So those of you who are saying all you need is IPS in this exam, no, you need to have medicine. And those of you who are just saying all I need is medicine, no, you need the social part. So you have to balance it 50-50. Sometimes the social part may be more. If somebody is crying, you don't want to just start asking them questions after questions after questions and they're crying. You know, is it appropriate to move your chair in the station? Yes. Goodness. Somebody who has lost their husband because of a suspected brain tumor, and my chair is this far. Oh, I'm very sorry because you have lost your husband. My condolences to you and your... What is that rubbish? If you feel it is appropriate to pick up your chair and move it closer to the patient, lift it and move closer. Okay? Don't be awkward though, because some of you want to reach out and touch the arm or touch the... You'd rather move the chair, offer them the tissues. These are little things that maybe you may not have done in your country, okay? Or in my country. Okay, if somebody starts crying, we just tell them, come on, everybody dies, come on. Okay, it'll be okay. But in this country, they're a little bit better. And I've learned so much from them because it is not only medicine that heals a person. Hope is a very important thing for you to have as a doctor, and compassion. These big things, okay? Hope, compassion, medicine have to go three and three together, okay? Your doctor's table. Do you have to use everything in the room? You don't. You don't have to use everything on the table. If the patient is coming for a neurological examination and there's a blood pressure cuff, it's a trap. You don't have to check their blood pressure and say, now I need to put on the cuff and check your blood pressure cuff. Okay? If you're teaching a student, they also want to see, would you teach them appropriately? I'll talk about that a little bit later. Let's keep moving. Let's talk about settings. And now, another new thing I want to introduce to you, and this is what I'm going to be talking about. I always try and revise my cases again and apply them to mostly what is happening in the NHS, because I realize all these examinations, all these entrance exams are coming up from problems that international doctors are having in the hospital. So now you have, like in our hospital, you can have 3 cases of medical errors. I know definitely the Plab will have to bring something with medical errors, or somebody has forgotten a treatment, or somebody talked to a patient inappropriately because of their sexuality, or somebody is having stress in work. I know, goodness, they're going to bring this in the exam. I talked to my recent class about pediatric cases. If you think about it, you can predict the exam. First of all, they say, okay, the patient, the child is not walking properly. So when you're studying, you just can't focus on children who have delayed walking. It's a very common thing in every hospital. Delayed walking, very common. Now, if you're studying for an exam like this, you want to think delayed walking, delayed talking, okay, delayed puberty. That case hasn't come, it's bound to come. What is another delay? Another delay in teething. My child is 1 year old, doctor, and I've not seen any teeth. Can you go research on these cases? Okay, other things are, what is something else that I taught about? Delayed puberty is another one you can go look up, or precocious puberty. Of course, now these are not come. These are all future cases, guys. Go and read up on them, and I hope you're taking good notes. Please, over prepare for this exam. It'll really serve you best. Anyway, let's go back to the GP clinic. GPs treat all common medical conditions and refer patients to hospitals and other medical services for urgent and specialist treatment. If you are in the emergency room and a patient has come with a referral from a GP, you have to think twice before you send them out for another referral to a clinic. Why would a GP choose an emergency room? They are thinking it's an emergency case. So if the GP is concerned that this child is not gaining weight appropriately, and the child comes to you and after a couple of questions you say, I'm going to send you to an eating disorder clinic, you fail. Why? Why would the GP send you to? The GP can send to an eating disorder clinic. Why did they send to the emergency? There might be something hidden that you're not picking up. So you're just thinking, oh, the child is not eating, anorexia, bulimia. No, the child could have another condition that is preventing weight gain. What are the alarm conditions of lack of weight gain in a child? Diabetes. So be very careful. You want to remember where you are. There are two types of doctors who are blanket doctors in life, GP and emergency room. Their history is very broad because they're casting a big net to try and capture anything that could be going on. So be very careful if you notice that you are the FY2 in the GP clinic or you are the FY2 in the emergency room. Okay? Now, they focus on the health of the whole person, combining physical, psychological, and social aspects. Absolutely wonderful. On the healthcareers.nhs.uk. And if you want to go and find out how much they earn, there are other little links that you can go start when you get employed here. You don't get too alarmed that you're not getting paid enough. Anyway, in the GP clinic, who can come? Somebody walking off the street, somebody who's coming for lab work, somebody who's coming for a follow-up visit. Okay, so for example, last time when I was in the GP, if a patient comes in and they have epilepsy, okay, it is diagnosed, my dear friends. There's no need of re-diagnosing something that has been diagnosed. Okay, the labs, it shows on the paper the patient has epilepsy. It's a follow-up visit. So what are we doing in this case? We are doing a follow-up. So of course you have to gather data. When was this epilepsy diagnosed? How have you been dealing with epilepsy? Are you taking your medications well? Anybody else in your family who has epilepsy? You know, in your last visit, did they tell you what epilepsy is? Yes. Do you know what the corpus callosum is? The corpus callosum is a device. Oh gosh, nobody needs to know that boring stuff. The boring stuff is for us when we're having our parties and we can enjoy medical jargon. Be fair to the patient. Speak in simple language. Okay? Little bit information about epilepsy. How are they dealing with it? Epilepsy in a male and epilepsy in a female, two different types of stations. Why? Because if this woman is in child reproductive age, you have to make sure she's on contraception because of the teratogenicity with anti-epileptic meds. How can you fail to ask sexual history for a woman who has epilepsy? It's not safe. It's not safe. Okay. Who else is with her in the home? Her husband, does he know how to put her in the recovery position? So you see, you have to think, where am I? I'm in the GP. Is it a man? Is it a woman? A woman needs a little bit extra if it comes to epilepsy, because you're thinking further down the lane. And in the end, you may want to tell her, if you're thinking of having children, let us know, because we have to adapt your medication to a pregnancy. Okay. In the meantime, she has to be on contraception, and sometimes it's double contraception with a barrier method like a condom and OCP. And if she's on OCPs, there's a relationship with anti-epileptic drugs and decreasing the potency of OCP medication. Broad thinking, guys. Broad thinking. That's what I sell. Okay, next. Now, any diagnosis that comes to you, you have to find out the past history, the medications that they are taking. If a BNF is there, does it mean you have to open it? No, it's a trap. Why would I want to open a BNF if I know what the medication is? You don't need to fake open the BNF because somebody told you, open the BNF in every station. No, you don't have to. If you feel the need to open it, and open it quickly, talk about it, and that's it. But don't fake open a BNF and say, I can see that you have epilepsy, then you shut the page because you don't want the examiner to see that you cannot open the BNF. If it is a lab work case, you have to give enough time to explain lab work. Why, if a patient is coming in and we have seen that their labs, their cholesterol is high, the BMI borderline high, we may start them on statin therapy. You may want to address the labs in around 2-3 minutes of the station. Don't push it for 6 minutes, because what if they have questions? All right, and remember how I told you to deal with labs. You just can't pick one lab and say your cholesterol level is high because of your diet. It could be because of family history, okay? It could be because of other factors, all right? You want to try and look at labs in a combined level and separate, okay? Now, can your transgender patients come? Yes, they can. I said here, they are everywhere. They are everywhere. Not only the GP clinic, and I don't want you to refer to them as we have all these other patients and then we have the transgender patients. No. Everybody is alike, and you cannot discriminate against anybody's sexuality. But now it is important for you, if your medical school did not give you any exposure to deal with transgender patients, go back to the books and read about it, okay? Read about transgender cases. For example, now let me see if we can give you an example of a patient. Let's say they are transgender, okay? And they are in the process of maybe transitioning from male to female, okay? And you walk into the station, and in front of you is sitting a male person, okay? And they say, my name is Jennifer. You have to keep your face very neutral. You can't say, Jennifer. You're Jennifer and you have a beard? No. And why am I teaching you this? Because you need somebody to teach you how to deal with transgender patients. I had never dealt with transgender patients until I came to the first one. And I had to go for a class. Why? In order to better service them. So let me give you a little bit of a lecture on this type of population of patients. First of all, keep your religion, your morals, or your ideations about sexuality in a box. You do not want to be biased. You walk into a room, a patient is visibly with a beard, and they're saying, my name is Jennifer. You greet them as Jennifer. You do not say, what is your real name? The one your mother gave you, the one, your God-given identity. Can you tell? No, we don't do that, okay? You call them what they want to be called. You don't make a joke about it. You don't, okay? You don't look uncomfortable about it, all right? All their life, maybe they've been dealing with people who discriminate against them, and then they come to the hospital and they find somebody who is discriminating them, okay? So you find out, okay, Jennifer, how can I help you today? Well, doctor, I want to have children. That is a common thing that some of our patients have come into the hospital with. All right, if anybody else came to you and said they want to have children, what is your response? You smile. Okay, this is a big step. Are you thinking of having children and being a single parent? Or do you have a partner? Yes, I have a partner. Is your partner here with you? Okay, because sometimes if you have a partner, it's better for us to have a combined visit, because if they have questions, then they also have an opportunity to ask. All right. So your name is Jennifer. You're in the you're a male who is trying to become a female, and you want to have a child. This is good. Medicine these days has the adaptability for anybody to have children. What have you researched about having children at this point? Well, I know that it's a bit hard for people who are, in this transition of becoming a male to a female to have children. Okay, how far have you gone with your research? I've just begun. All right. So there are a couple of things I may need to know before we can talk about that. Do you have any medical conditions? Anybody in your family or immediate blood relatives, anyone having a problem with getting children? Yes, guys, you have to ask these questions. Are you on any medications at all? Yes, I am on a high hormonal therapy. What is the name of the hormone that you're taking? I'm on high estrogen. Okay, so now a male who is transitioning to a female can be on high dose hormonal treatment. A female transitioning into a male can be on a high dose testosterone treatment. What do these hormones do? So now you have to explain to her, to Jennifer, is that whenever you are under high hormonal treatment, it can suppress the ability to have children. Normally, it can, okay? So now high estrogen treatments can suppress the production of sperm. And you also even want to make sure that you find out from Jennifer, where in the cycle of her transition is she? Is she just beginning? Is she in the middle? How long has she been having the hormones for? Okay, or has she already had the gender reassignment surgery, the GAS, gender reassignment surgery, the GRS, gender reassignment surgery? Because if you are further along the process, it is harder to get children. Why? Gender reassignment, they will take out the testes, or there's manipulation of different reproductive organs. So once the testes are out, there's low chance of producing the sperm that can be utilized for you to get a child. So this is where your history should be. Why is your history in diet and exercise? Have you traveled out of the UK recently? Do you eat a healthy diet, like morning, lunch, and dinner? Very good. Do you exercise? No. Why don't you exercise? Why are you talking about that rubbish? There's so much to talk about the focus of the disease, of the focus of the complaint. So finish with the focus first, and then you can move on to the maftosa butterflies and all these other things. Samtofa, famtosa, maftosa. Okay? Now, and I hope it's making sense to you. In this patient now who says they want to have a child, find out where they are. What stage are they in? Are they being followed by any specialists? Have they talked to the specialist about it? Where is their partner? Can we also have a meeting with their partner? And then now you can start with the medical knowledge. It is possible for you to have children even if you are in the process of becoming a female from a male. Okay, there are certain things that can be done. We can harvest sperm, okay, or you can give a sample of the sperm, which can be kept for a later date, okay, because in the process of having children, the sperm has to meet the ovum. There are different ways of this happening. You can have a surrogate mother, where you can have a woman who will agree for her ovum to be fertilized outside the body and implanted in her. Okay, there is an option also for adoption if you're interested in it. Okay, but what we need to do first is to see where they are in the process, and if they are far along and they want this child to be birthed from their own sperm, sometimes it's important to slow down on the treatment of the transition from male to female. Okay, let him increase his sperm count, take a sample of the sperm, save it, okay, then he can continue on. But if he has reached the gender reassignment stage, then the chances are very slim. We have to look at other options. What do you think about this, Jennifer? You know, there's a lot for us to discuss, and I want to invite my consultant to come in and talk to us about this. It's not a difficult case to deal with. Even in the other way, a woman who is coming in and she's she's transitioning from female to male. Same questions. Any family problems of anybody who is having a hard time giving birth? Are you on any medications at all? Yes, I am. I'm on a high testosterone treatments. How often? How many times a day? Side effects? These are the things you ask. And then now you tell her, have you reached the gender reassignment phase? What is this, doctor? They take out the womb, they take out the ovaries, and sometimes they can even do a different reconstructive surgery. And this is the final stage where now you can even get the male organs. Have you reached this phase yet? If she has taken her ovaries out and the uterus out, the chances of her carrying the child are quite impossible at this point, you know. But if she's in between, we can slow down on the testosterone treatment, okay? There are drugs to help with ovulation. They can harvest the egg, okay? They can do in vitro fertilization. And please, guys, we never say artificial insemination. Artificial insemination is what they do for animals. You can never tell the patient, we are going to artificially inseminate you. No, it is in vitro fertilization, okay? But in the end, what is the role of the FY2? Broad. Thank you for coming in. I've discussed with you a couple of options. We may need more specialists or expertise ideas on this. I would also want to make a team. Let's team up with your transgender specialist. Let's team up with the rest of my team here. Let's come up with a plan. Have a follow-up visit. We'll sit with you and your spouse, and then we can discuss options. These days, medicine is so well advanced. You can have children, but we also have to make sure that there are no family influences or any genetics that can slow down the process, okay? And also it's important for you, Jennifer, to realize there may be an option for you to slow down on your treatment from becoming male to female, be able to harvest some sperm, and then afterwards we can continue with the treatment. How does this plan sound? It sounds great. Thank you so much for coming in. If you have any questions, my name is Dr. Lianne. I can give you our card or information about it, okay? And there's also some information I can print out for you. I never say leaflets. I'll give you leaflets. Why? It's such a very nonchalant. Go read about it. No. I can print out some documents about it. We can even see if there are some community programs where there are couples who have successfully had children during the transition from male to female. Good. See, that's why it's important to pray before I teach you guys, because I get some good ideas as I teach. That's another good idea. Are there some community groups where we can have sponsors? And a sponsor in this case would be somebody who has gone through the process of having a child, even as they're transitioning from male to female. It may be wonderful to have a meeting with them to see what challenges that they have had, to see what they expected, how life is. These support groups are available. Come on, okay? So dare to be different. Let me talk about this GUM clinic. How are we doing on time? I'm very surprised I've not even received any calls that I am needed. No, good. Anyways, GUM clinic, the same website. Literally, guys, if you just take a little bit of time and make a nice bonfire of the scripts or throw them in the rubbish, and now focus on gaining knowledge. He who seeks knowledge will find it. All what I'm teaching you is information that I've sat down on my days off and gathered. GUM clinic, the principal role of GUM, and please, if you've taken any class with me, don't call it a GUM clinic. It's you're cheapening it. It's genitourinary medicine, not gum, chewing gum, okay? Their role is prevention, detection, management, and control of sexually transmitted infections. They also manage a number of non-infection medical genital problems such as dermatosis affecting the skin. Yeah, do we have cases that have not appeared in the Plab or the WAST that could appear in the GUM clinic? Of course, scabies, pubic lice, genital manifestation of warts. Go and read, look at pictures. Where are they getting the pictures from? Google. Okay, so even as you're studying with your friends, say, what can they bring to us? Let's anticipate a station. Can you please go and read on genital manifestations of scabies and pubic lice? It could come next week. And I don't work for them, okay? And my mind is just very active in thinking of future cases. And I'm so happy because these future cases that I've taught, they have come, okay? Enuresis is now a wonderful case of bedwetting. I said if the child is having screaming in the night, they may bring something. The child is walking in the night, okay? The child cannot sleep, okay? My child is, which one is, my child is very aggressive. My child is fighting a lot in school. Is this ADHD? Is it a behavioral problem? Please, please, please. GUM Clinic, this Health Careers website talks about all these things that can happen. Chlamydia, have we seen it? Yes. Gonorrhea, have we seen it? Yes. Herpes, have we seen it? Not yet. Warts? No. Syphilis? Maybe. And even when you're getting a case where it's sexually transmitted, you should always have this triad: chlamydia, gonorrhea, syphilis. Always rule out those three things. You can never just tell a patient we'll check you for gonorrhea. We always check for more, making sure. And if they've had unprotected sex, please, you have to offer them testing in HIV and hepatitis, because there's also a risk with that, okay? Another big thing also with these cases could be here, skin biopsies and the insertion and removal of contraceptive devices, including contraceptive implants and intrauterine devices. Can this be put in the GP clinic also? Yes, but also in the GUM. Now, if we're in the GUM clinic today, let's say, and a patient comes in with gonorrhea, with HIV, I've told you already, a diagnosed case, simple few questions. When did the symptoms begin? Okay, what symptoms are you having? Don't first start saying sorry, right? They've been given the diagnosis already, okay? How are you feeling now? I'm feeling a little bit weak, doctor. Any fever? Yes. Can I check your temperature? You have to be able to adapt. Why will a patient tell you, I'm feeling a bit feverish, and you don't do a temperature at that point? I would say it. At some point, I want to check your temperature just to make sure you're not having a fever. Okay, and then now when it comes to sexual history, because some of you love to overly signpost. One line of signposting is fine. Is it okay for me to talk to you about your sexual history? Some of you say, is it okay for me to talk to you about your sexual history? I have some very uncomfortable questions. They may seem silly, but it's very important for me to ask them to you so that I can get a better picture of what is happening, because you're taking a minute to signpost. Please, it's showing you're not using your time effectively. Simple signposting. Listen to a good sexual history, or even some of you have better sexual histories than me. But when I do my sexual history, I always make sure, first of all, is to ask, are you sexually active? Because you never just want to ask the patient, are you having safe sex? What if they're not sexually active? Okay, number one, are you sexually active? Okay, then the next thing I ask is, do you have a stable partner? Yes, doctor, I have a stable partner. I live with my wife. Okay, in the last 6 to 8 months, have you had any other partner other than your wife? Yes. When last was your encounter? I'm now on number 4. Okay. When last was your encounter? 3 weeks ago. Did you use any protection like condoms or diaphragms? Why do you ask that question? Is because I hate to be interrupted by saying, do you have safe sex? What do you mean by safe sex? Safe sex is using condoms and diaphragms. So just ask a question that explains it. Do you use safe sex with condoms? No, I don't. You cannot ask anybody, why don't you use condoms? Do you want to hear the answer to that? People can do whatever they want, okay? And then now you have found out the biggest risk, exposure. You found out that they're having multiple partners and they are not using any protection. Done. Now you go in and you ruin the case by saying, do you prefer oral sex? Do you prefer anal sex? Or do you prefer vaginal sex? Come on, doctor. You already have the risk factor. You are now ruining all the IPS by being it's too much. Have they complained about mouth sores or anything else? No, they haven't. So leave those questions alone. And I know some people, okay, fine, the risk of HIV in male-to-male interactions is through anal sex, that's fine. But in a case where you've already been given gonorrhea already, and they've told you their other partner is a male, you can't say, okay, it's a male person who is in front of you, and then you ask him, do you prefer anal sex? I literally shiver at such questions because they totally ruin your rapport. Some things you just have to reason out and give yourself answers, okay? Please, please, please. And then after you've done your sexual history, you want to move on because any GUM case with a sexually transmitted infection, you have to make sure you say partner notification and also anticipate that they will fight you. Nobody wants everybody to know that they have gonorrhea. I don't want people to know I have the gonosh. So you have to anticipate they'll fight you. So why would you want to only break this news after 2 minutes? Move your breaking of the news in sexually transmitted infections to be before 3 minutes, please. And this is another thing I teach in the course, the 3-2-3 method. It's a new 2020 thing I'm teaching. 3 minutes for data collection, 2 minutes for physical exam. You have to make sure you're very sharp with your physical examinations. Boom, 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 done, 2 minutes. All exams done in 2 minutes, guys. You can't do a physical exam for 4 minutes. It's too long. And then in the end, your last 3 minutes is to explain what is going on. Sexually transmitted infections, number one, you tell them, you have gonorrhea. It is a bacterial infection that is spread through body fluids, through your interactions during sex. They may ask you questions, you may need time to answer it. Then now you have to say, from today, please, we may need to give you some antibiotics, ceftriaxone, IM, and then you can go home and you get whatever you're gonna get, okay? The third thing, we want you to follow up with us in the GUM clinic after a couple of days to make sure that you are free from the infection, so we'll have to do the tests again. This is for your chlamydia, gonorrhea, syphilis case, okay? Number 4, partner notification. I never say, and now we need to tell your partner. No, you never want to frighten a person like that. How do you talk about partner notification? You always try and scare the patient a little bit by saying, you have gonorrhea. I'm glad you came in, we did the tests, and we are giving you treatment for it. Because if it is not treated, it can cause up to life-threatening complications of the disease, especially in women. It sometimes goes to the tubes and can cause inflammation, okay, and then it can even cause infertility in the future. Because of this risk, James, we have to let your wife know. And your girlfriend who you had sexual intercourse 3 weeks ago. Okay. The life-threatening complications are quite severe, and even their policies that we have been given, we are not even the ones who make these policies, they have been given to us by the Ministry of Health. For sexually transmitted infections, the partner has to be notified. You see how I did it? Instead of saying, and now we have to tell your partner, what is your partner's full name and her telephone number? Get out. You're never gonna get an answer from a patient like that. You have to reason, talk to them and reason. Even HIV, you say, I'm glad that we're going to start the treatment. Why? Because it's a very resistant virus. Anybody who has been exposed is at a great risk of opportunistic infections, including tuberculosis. This is why we need at this point to consider all those who have been exposed. Okay, we will refer you to the GUM clinic. They have a partner notification program. They will call your partner. They can ask you, how are you going to make sure that they're not going to give my information? You have to know how partner notification is done, guys, so you take it as next level of reading about partner notification. Because I know you won't read, let me tell you. What they do is they call, and if James wants to know exactly what partner notification is, you say, they will get the information from you, their contact number. We will give them a call and tell them, hello, are you Jane Smith? Yes, I am. Please come to the clinic. It is important for us to do a couple of tests on you, okay? And if they ask us, why do you need to do tests? We say vaguely, you may have been exposed to a viral infection, you may have been exposed to a bacterial infection. We will talk more about this when you come in. Okay, we don't give any details over the phone as to why they need to be tested. We talk to them when they come in. They will ask us, who has given me this infection? We cannot even say, you, James, are the one who has given your wife the infection. No. We tell them to consider their recent exposures, but our main focus is to test them. We give them more information, but we never give the exposure's name out. Please, guys. And then another big thing, when do you say partner notification when you're in management? You never start your management by saying partner notification, because you'll fight. You won't have time to say antiretroviral treatment. You won't have time to say GUM clinic. You won't have time to say safe sex. You keep it for the end. Number 1, antiretroviral. Number 2, safe sex with condoms. Number 3, GUM clinic. Number 4, partner notification. Okay? Be very, very careful. Okay? Other things, let's say you know, a mother who has had a sexually transmitted infection is coming because her child is having maybe problems, has a rash, has you know, stuff, pimples around their face, has discharge from their eyes, whatever the case may be. You absolutely have to send this woman for testing if you're considering that a mother has transmitted infection to her child. Many people forget this, okay? So you treat the child for the infection, the rash, or whatever lesions they're having around their face or discharge from their eyes, but you also tell the woman, we need to send you to the GUM clinic, okay, so that we can be able to evaluate even the source of the infection so that the other person can also be tested. How are you doing? 129? You must have said your prayers. I haven't received any calls. What have we talked about so far? I've talked about the GP clinic. I've talked about a little bit about some of the cases that you may have, maybe with a patient who is transgender. Update your transgender knowledge. They can have children. Yes, okay? The males can have children. Of course, they're not going to have a womb implant. So don't offer those crazy therapies that are not yet available in the NHS, but we can preserve their sperm. What is it called? Cryopreservation. We can preserve their sperm. We can freeze it. If they are a woman, we can preserve their ovum for when they are ready. Okay. Another thing I've talked about is a GUM clinic in a couple of cases, including new ones that I want you to go and read about. Please. Okay. If I insist on something, you better go and read about it. Now, here's where, because I do emergency room. This is where we have problems, especially for new graduates or new people who have come into and they pass the Plab. I've come, I want to work in the emergency room, and then they're put on suspension after 3 weeks. You can pass the Plab and lose the GMC license. Why? Because you are not keeping up with medical knowledge. So sometimes even failing the Plab is a blessing, my dear brothers and sisters. Maybe God is giving you a chance to improve your medical knowledge. I've had very sad cases where people pass the Plab, pass the MRCP, they go in and they do a small stupid mistake, and then now they've been put on suspension. You can't work for 2 months. Why? Because they are trying to follow management that is not appropriate. God, I really, even something like this, let me give you a scenario. A consultant tells an FY2, I want you to go and give this certain medication to a patient. And the FY2 just goes and gives the medicine. The patient gets adverse reactions, ends up on dialysis. They are called for a tribunal meeting, or that's what they call them, tribunals, or an investigation. The poor FY2 says, the consultant told me to give the medicine. And the consultant asked, oh guys, don't interrupt. The consultant is asked, did you order this medication? The consultant says, I'm not too sure. You know, I have so many cases that I deal with. I expect my FY2s to go and cross-check and cross-reference the medications that I say. Poor FY2, out of a job now. Did they do something wrong? No, they were following orders from a consultant. Did they check the order? No, they didn't check. Why? Because they're used to that. What do I need to do? Okay, I'll go do it. And they go do it. Dude, it's your license. It's your license. The world is cruel. Can you imagine you've moved all the way from your country, you've moved your family, you've gotten your kids in a good school, a doctor comes and tells you to go give a medicine and you don't check? So why would I give you a script and you don't check the management? Why even I tell my doctors when I teach them, please, I could be in error. If I'm teaching you something and you go and find it's not the truth, come and tell me, let's help each other. But you always have to verify medicine that you are giving. This poor doctor is out of a job. Is the consultant still working? Yes. Why? They covered themselves. They said, when I tell my team what to do, I expect them to go and cross-reference. Very sad case. This is why I emphasize people, you have to be continue with knowledge, continue learning, make your own scripts, okay? An emergency room is the most dangerous place for you to have no knowledge. In the exam, if you see you're in emergency room, all your antennas have to be up, okay? First things first, any condition that is unstabilizing the patient, you need to do vitals. And what are some of the things? According to this website again, where are we here? healthcareers.nhs.uk, go read it, okay? It says, the duties of an emergency room FY2 are to stabilize the patient. I like this job. Excuse me, I really enjoy teaching the Plab, okay? The patient could have gone to the GP clinic and came to the ED. Why? If the patient was referred to the ED by another doctor, does it make sense to refer them back to another outpatient? Think about it. What is the focus of an emergency room doctor? So those of you who say, I can never remember where I am, I can never remember even the patient's name. Stop. You have to remember, okay? Doctors in the emergency room treat patients with serious and life-threatening illnesses and injuries. If you are in an emergency room setting and in the first minute you don't mention vital signs and you're working with me, I'll give you a small punch. I'll be like, wake up. You're in emergency room and you haven't done vitals. Who comes to the emergency room? They pick them from the roadside, the streets. They are passing out or in their cars. Drug abusers, addicts, homeless people with strokes. You have to be able to catch the first 4 things in emergency room that you must absolutely catch. First thing is sepsis. You can never miss sepsis. Then number 2 is hypoglycemia, okay? Then the next thing is head injury and strokes. You can never fail to ask this as differentials in the emergency room. And so, for example, if I give you a case, the emergency EMTs have brought in a woman who they found wandering in the streets, okay? And you go in and she's like, hello, my name is Dr. Lianne. Where am I? Oh, am I in the restaurant? Somebody help me. And then you start. Can you tell me apple, table, penny? Can you repeat after me? No ands, ifs, or buts. What are you doing? Which emergency room doctor starts an examination with an MMSE? Get out. You can't. The woman is unstable. You find out, first of all, you say, you have to calm her down. Samantha, okay, please have a seat. The EMTs found you, all right? And yeah, I'll answer your questions in the end, yeah? So just type them for me. We have time. My consultant is, maybe he's still having lunch. Anyways, I'll answer them after we're done. So now, the patient has been brought in by the EMT. They are confused. The first thing is to find out, Samantha, okay, do you know where you are? I don't know. I think I'm in a restroom or in a restaurant. Okay, my name is Dr. Lianne. I'm one of the juniors in this department. Okay, I'm here to help you. What is one of the last few things you remember? Do you remember anybody you were with? No, doctor. Where am I? Where am I? I can see you are looking around, Samantha. Anything you're seeing on the roof? Anything you're seeing behind you? I can see you're not comfortable. And just to make sure everything is okay, I would like to check your vital signs. Let me make sure your blood pressure is fine. Let me make sure that your pulse is okay, and also to check your temperature. Why? She's elderly and she's confused. The first differential with elderly confused people is sepsis. You cannot miss that. Please. Okay? Then the next thing is, if the vital signs are okay, then now let's find out a little bit more about you. You are walking on the street. Where do you live? Do you remember your address? Do you have a purse with you? Do you have an ID card? Do you remember any telephone numbers at the top of your head? You can't believe it, guys. Even sometimes in some of the exams, the patient says, I have this phone. And don't laugh at my iPhone 4S. It's one of the ancient dinosaur phones. I have my phone. I don't know how to use it. And the doctors have said, okay, can I take a look at the phone? And they touch the phone and the phone is dead. Okay, let me see who has a charger for the iPhone 4S. We'll charge your phone. Maybe there's an important number we can get to see who your family members are. Please, this is the first step of emergency room doctors. All right. If somebody's coming in with an emergency, they've been brought in by the ambulance. Oh, help me, doctor, help me. You can't just go there and start asking, when was the last time you left the country? Or when was the last time you did exercise? And no, vital signs, vital signs. A patient is on the bed crying and groaning and paining and having pain. They fell off or they were hit by a car and they have a pelvic fracture. Doesn't it ring a bell that you might need to do a TLS protocol? GMC doesn't have to tell you do a TLS. No, you are thinking pelvic. John Smith has been brought in by the ambulance. He just had a road traffic accident. Examine the patient. And then you go in. James, is everything okay? Okay. Doctor, I have pain in my pelvis. Please help me. Can you give me pain medicine? Yes. I will give you morphine 10 milligrams IV. Please. You have to think. This is a trauma. They don't need to tell you do ABC. You have to start from A. James, let me just make sure that everything is okay. Can you open your mouth for me? Keep talking to me. I need to make sure that you can speak or that there is a good air passage in your windpipe. Can I see inside your mouth? Any loose teeth at all? Are you able to stick out your tongue? I want to make sure there's no bleeding. Because if you have loose teeth and if you have any secretions in your mouth, we may have to suction out those secretions. Do you feel like you're choking in your throat? No, let me feel. Okay, that's airway, guys. Can I feel your windpipe here? He is screaming bloody murder. Check my pelvis, give me pain medicine. James, I'm sorry, I have to follow a system because if I give you pain medicine at this time, it is going to mask all areas of injury. It will be hard for me to find out. Okay, A, B, C. C is where you deal with circulation. And circulation is starting from the chest, okay? So you have your looking for bruises, okay? You're looking for any abnormal bruising in the chest, okay? You are also listening to those lung sounds which kind of overlaps B and C together. I teach this in join my class next week. I'll give you more information. But I'm just giving you highlights because many of you maybe I'll not see again. I want you to be equipped for this exam. Please think before you act. Just because a patient is asking you for pain medicine doesn't mean you need to give them, especially in a traumatic case. Circulation involves, let me go back to circulation, involves the chest, the abdomen, the pelvis, and the femurs. You have to make sure they don't have a femur fracture. Have you had a patient who comes in and they're complaining about the femur, the pelvis, and then you do your spring test and it's positive? People abandon the femurs. You have to keep going because the patient can have a pelvic fracture and a fracture of the femur. And then you're wondering, Dr. Lianne, I don't know why I failed this primary survey. Oh, you found the pelvic fracture? Yes. Sometimes there's a femur fracture. I didn't check. See? Another big thing is I teach the management triangle. Whenever you are dealing with emergency cases, you have to put yourself in a triangle. I wish I had the picture here. Patient at the tip of the triangle. On one side, you have your vital signs, and on the other side, you have the intervention. I have a YouTube video, I think, about it. It's the 3-hour cases of in the NHS. Go and look into the emergency triangle that I wrote up. You talk to the patient first. What is going on, James? I am having pain in my pelvis. Okay, then I need to do an assessment on you first to make sure everything is okay. A, B, C, D, E. Okay, airway, blood pressure, airway, breathing, circulation, disability, and exposure. Can you at least put the vitals on? Because if they are severely hypotensive, 60/40, you want to put in your 2 large bore IVs. You want to start them with a fluid challenge. You never want to bolus somebody with 1 liter of fluid on one arm and 1 liter of fluid on the other arm, and you've not listened to their lung sounds. This is why ABCDE is so important. You'll put the poor guy in fluid overload. You don't know his background. Anyways, so in the emergency room, you have to first stabilize the patient, regardless of whether they're coming in with confusion, brought in by the ambulance, a parent has brought in their child, staff members have been injured on duty, they can come through the emergency room. How many times have we had people, our surgical registrars, I cut myself during surgery. Oh, what did you cut yourself with a 10 blade? Okay, before you start saying, do you have the 10 blade or do you have the syringe of the needle that you injured yourself with? You want to ask him, where did you cut yourself first? Focus on the patient. Can I take a look? Maybe it's bleeding too much. Maybe he needs to put a compression on it. Some of you are focusing so much on, can I see the scalpel? Can I see the syringe? Okay, you want to find out what they did afterwards. Did they clean the area? If somebody has stuck themselves with a syringe and they did not clean the area, you want to say, please, let me just interrupt you. Get some water and clean the wound and make it run through water and try and express some of the blood. Okay, and then because the script says the chances of getting HIV are very slim, you come and tell somebody who has just stuck themselves with a 16-gauge wide bore needle that their chances of HIV are less. It's a lie. It's high. If the span or the time of injury is within seconds, guys, the risk of HIV is high, and the risk of hepatitis B and C is even higher. But because the script is saying, oh, the chances of getting HIV from a needle stick are very slim, then now you come and tell the nurse or the medical student that their chances are slim. That's not the truth, because you need to find out when you cut the patient or when you are suturing the patient, okay, and you injured yourself, how many seconds would you say lapsed? It was almost immediate. Was there blood on the needle? Yes. So there could have been a chance you transferred blood from the patient to yourself. Why do we start them on antiretroviral treatment? Because the risk is considerable. So be very careful about just copying, pasting and saying, oh, HIV virus does not live long on an inanimate object. Get out. Okay. Another thing, so I've talked about the trauma cases. Delusions, that's another thing. Not every case that's coming in is delusional. I try and trick doctors in my mocks. And all I have to say honestly is the patient was wandering in the park and was brought in by the police. And they start saying, psychosis. The patient has psychosis. The patient has hyponatremia because of an electrolyte imbalance. They may be on citalopram. Wow, what are the chances of that? Why didn't you ask for my vital signs? Why didn't you ask the patient if they have a fever, if they are coughing? And people say, I need to do the MMSE as the first thing. The MMSE of your 30 points or finding out whether they have a fever, which is more important in the emergency room? Think about it, okay? And if this was your country, you would not, trust me, I bet 1,000 billion pounds, you would not start an MMSE in an emergency room with a confused patient. But when you come to this country, it's like you've been brainwashed and now you're starting MMSE in an emergency room. Go back to the light and the truth and the basics of medicine, please, please, please. Now, here, other things, adverse outcomes, exacerbations in disease can come in the emergency room. What do I usually see? Asthma. Why are they coming back? Okay, teaching of students happens in the emergency room. Why do we bother to teach students anyway? Why do we give them knowledge and not follow up with understanding? A medical student, you have to gauge understanding. First thing in the beginning, what level are they? Are they just the basic first year medical student? You have to gauge the teaching to their level of understanding, okay? Are they a fourth year? You expect them to know a couple of things. So you have to find out these things, okay? And then the teaching is not a quiz. It's not an OSCE. So you can't just tell them, you tell me what to do for CPR. What do you do in CPR? How many compressions do you give? How many breaths do you give? What is the depth? They have come to your teaching session. Teach them. But after every few minutes, you want to check, okay, do you remember how many compressions we are giving for an adult? Yes. How many? 30. Good. What are some of the landmarks you want to make sure? What is the depth of the compression? Those are the questions you ask the student. You never teach a session and then say, now repeat to me everything that I've taught you. You don't do that, okay? And where's good? I'm so glad I added this case. Teach a medical student to do a respiratory exam. How are we doing on the time? It's become a 2-hour session. Forgive me, guys. Let me just keep going because it seems there's a good blessing. My consultant is not calling me. As soon as he calls me, I'll have to leave, yeah? But let me talk to you about this case. Easy case, but pass mark, very, very, very low. Very low. And even in our NHS hospital, I did a trick with my colleague. I said, can you teach me how to do a respiratory exam? We still laugh about it up to today because it was such a rubbish exam. We have forgotten the basics of teaching. Whatever you teach a student, they will remember. So you have to learn how to teach well. First things first. Hello, James, are you the student? Yes. What year of medical school are you in? I'm in my second year. How do you like the pulmonology floor? How do you like the ICU? It's really good. Have you seen any interesting cases at all? How are your studies? Choose 2-3 questions. Please, you're not trying to date the student. Why are you asking them a whole minute of rapport? It's too much. It's too much. 2-3 questions and then say, thank you for coming for my teaching session. I'll do the best that I can. There's a lot to learn, but in the end, we can always refer to the books, and I want to maybe give you a mini quiz just to see whether you're paying attention. If the student is not paying attention, will you just stand there and keep teaching and the student has gone to sit down? I tell my doctors in my course, I say, you have to be real. And one of my recent doctors literally said, okay, let me just stop the teaching session now and just talk to you a little bit, James, because You came in for the teaching session, but you're not paying attention, my friend. You know, I'm trying to teach you, but you're seeming a bit distracted. You're looking around. You're sitting so far away. Is everything okay? Yes, everything is fine. You know, even this session, it counts towards your professionalism, because at some point I will be requested to give an evaluation of you. I don't want to have to give you an evaluation that is going to decrease your grade, you know. And even more so is in the future, you will be in my position. You will be a doctor. You will need to know how to do this examination well. It could save a life. So please stand up and come here to where the mannequin is. Let me teach you how to do a respiratory exam. Clean 12. Why? He was being real. You cannot teach yourself. If the student is ignoring you, just interrupt and say, James, please pay attention. What I'm teaching is very important. You know, it could save a life one day. Would you do it in real life? Yes, so do it in the exam. Don't be robotic. Don't be like, James, are you listening? And then even when you're teaching, you have to interact the session. It has to be fun. Some of you doctors, I know you are like very high level professors, cardiothoracic surgeons in your country. I'm sorry, this is an FY2 exam. Too much knowledge sometimes can be a hindrance. You have to dumb it down a bit, okay? All the specialist treatment is not appropriate. Basic level FY2 is what is required of you. So do basic level first. So let's go back to James. James, thank you for coming in today. We are going to do a respiratory exam. Have you seen one done in the past? No, doctor. Do you know why we do one? That's the broad picture. We do respiratory examinations when patients come in with coughing, shortness of breath, maybe they've had an injury to the chest area, okay, if they're having a fever, again, it's maybe a symptom of another disease. This is why we do the respiratory exams, okay? There are a couple of things that you may need to do, okay? You want to, first of all, take a history of the patient, find out when the symptoms started. A physical exam is going to give you more detail. And in the end, we always follow up with more investigations. And that's the purpose of teaching, to give them the whole picture. We just don't say, we are going to do respiratory exam. Here is the stethoscope. Boom, 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 boom. No, be organized. It's part of the consultation. So now you say to James, well, we have to know anatomy of the lungs. Where's my picture? We have to know the anatomy of the lungs, James. The left side and the right side have different types of lobes. The lungs on the left, there are two, left upper and left lower. Okay, and on the right we have three. And on the back, there are two on the right and two on the left. Do you know why we have only two on the left side? Because of the heart. Oh, yes, yes. Very important thing, lung sounds have to be done systematically and you have to compare side by side by side, okay? The first thing is to explain what you want to do to the patient. The procedure, the instruments you're going to use, you're going to be tapping a little bit, tell him to expose from the shoulder area all the way to the waist. Why? We have accessory muscles that can be used in respiration. Around the neck, the scalene muscles. Do you remember from anatomy? Very good. Isn't that a nice way to talk to a student? So you're not just saying, no, 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 no. You are making it a conversation. Okay? Then you stop. Any questions at this point? No? Okay, let's keep going. First things first is exposure. From the shoulders all the way to the waist. Don't use medical language, guys. Superiorly to the waist and medially to, leave it. Talk regular language, okay? And then, talk regular language, okay? Sorry, my African accent always happens to come out when I get frustrated. Leave it, get out, okay? Anyways, James, you're paying attention? Yes. Next thing you want to do after exposure, if it is a female patient, James, because of the breast area, you may want to have a chaperone. You may not need to have her remove her undergarments, but keep the room private, okay? Because she's exposed. Chaperone is very important. Make sure you clean your hands appropriately, clean them well with the hand sanitizer, and then now you can proceed, okay? You have permission from the patient. Next, you want to do auscultation. You can start with inspection. You can inspect the hands. Guys, not too many things. Inspect the hands. Check if there are smokers. Sometimes you can see a little bit of tar on the hands. Clubbing of the nails, that could even indicate maybe some heart conditions. All right. Then after that, you just want to look at the lungs. See, or the chest area. Is there like a paradoxical movement? Is there any bruising? Okay. After inspection, you're going to auscultation. Why am I jumping now? Because time has gone. Okay, so now I'm just hitting the main focus points of the examination. You can't go too much in detail, guys. You can't. You'll not finish. So now you move on to the mannequin. You say, remember I told you their right lobes and their left lobes also. Whenever you are listening to a patient's lung sounds, you have to listen twice in each area, and that's where most people fail the station. One, finished. You didn't even listen to the mid-axillary apical lobes. You did not. Bad practice that you're teaching James the student. Hold each position for 2 breaths. Start at the apical lobes. We never start lung sounds here. You always start at the top. And you always have positions mid-axillary. Here, the bases of the lungs. 1, 2, 3, 4, bilaterally. Never unilateral. Okay? So you've done inspection, you've done auscultation. You want to say, you do the same to the back. If you have time, do the posterior lung sounds. If it's a mannequin, how are you going to start lifting the mannequin and now you're wasting time? If it's a mannequin, good for you because that person is on the floor. Leave it, but explain about the lung sounds in the back. Then there is percussion. Percussion, you use the middle finger of each hand. Make sure your nails are short because you're going to be tapping. Can I teach you how to tap on the table? That is how you tap. And even when you go home, practice, because you're not going to let James practice on this on the student. What if the question says, let the student examine the patient? Then you let the student examine the patient. You can't say, oh, some other doctor told me that I should never let the student touch the patient. What if it changes in your exam? So some people are even doing tasks that are not on the question because they are so scripted. Be aware, okay? Teach James how to percuss. On the table, he can go practice at home. And then after all this, why did we teach him? We want to tell him there are different lung sounds I want you to remember. There's one called crackles. Do this to your hair. That means there's fluid in the lungs. A chest x-ray has to be done. Okay, it could be an infection. It could be a problem of the heart. There's other sounds like stridor, ronchi. I can give you some YouTube links to go and listen to these lung sounds so that you can master them. Percussion is very important. There is hyporesonance, low sounds, and hyperresonance. A hyperresonance sound is quite dangerous because it could mean the lung has collapsed. All investigations have to be done after this examination. Talk to him about it. So you see, you just don't go in there to teach. You give them the teaching, the rapport, of course. Talk to them. I always teach this thing, PECT. Procedure, exposure, chaperone, consent, discomfort. Okay? And then you do your inspection, palpation, percussion, auscultation. And then you give a little bit of educational, some abnormal things you may find. Even though it's another teaching like a knee examination or another presentation. There is a safety netting. Why have we done this teaching in the first place? So that you can have information for the future. If you hear crackles, chest x-ray, we may need to do lab work. But guys, teaching is very, very, very serious. You cannot teach the student the wrong thing. So learn how to teach. Here's another big thing. Where am I? Emergency room, yeah? In the emergency room, you can have people who walk in and they want to know about their family members. They want information. Can you tell me what is going on with my mom? Can you tell me what is going on with my dad? There are some phone calls you can get. Hello, I'm calling you because my mom was transported to you with a heart attack. Can you tell me what's going on? That now becomes breaking bad news over the phone. Does it happen in real life? Yes, it does. But does the FY2 usually handle a breaking bad news over the phone? Rarely. We usually say, just hold on a few minutes, let me get my consultant. But what if this happens to you in an exam setting? They want to see how you will handle it. And if you know about the policies behind breaking bad news, join me next week. Let me discuss this case. Even before we, I know I've taken an extra hour. Sorry. Some of you need to go. You may have a patient who is calling you from Australia. My mother is in your ICU. Please tell me what's going on. I have tried to call my brother. I have tried to call my friends. Nobody's answering the phone. I need to find out what's going on. It has happened in the past. Have I ever been put in a situation to break over a bad news over the phone? No, because I work with a good team. They will never put me in a position like this. But in the event that it happens, you have to be ready. Number one thing, and I'm closing my eyes so that I can emphasize, when you're on the phone, you have to absolutely do triple verification. First of all, you say, hello, my name is Dr. X. I'm one of the juniors in the ICU. Can I please know who I'm talking to? My name is Samantha Jones. Okay, Samantha Jones, how can I help you? Find out why she's calling. My mom is in your ICU. I'm in Australia. I need to know what is going on. Please verify your mother's full name and her date of birth. Her name is Melissa Jones and she's 70 years old. Okay. Can you verify one more thing, maybe her home address or her NHS number? Triple verification. Full name of the patient, date of birth, and an address, or an NHS number, and they'll tell you. And then now, you want to find out, if she doesn't tell you where she is, you can say, okay, after verifying that you are indeed her daughter, I can give you an update, but usually this is not our policy. We want to talk to you face to face whenever it comes to updates of loved ones. I would say that. Why? Because I'm showing not only the examiner, but I'm showing that I understand this is an exception. We usually want to talk to you face to face to give you an update on what is going on with your loved one. Can I ask where you are right now? What if she's 5 minutes away? Hey, Samantha, step on the gas and come to the hospital. I'll wait for you. People don't find out. Where are you? Where are you right now? I'm 10 minutes away. Can we wait for you to come in? Or, no, doctor, I can't. I'm going for an interview. Okay, so you're driving right now? Yes, I am. Is there a way you can pull over? I cannot talk to you in detail. It will give me more comfort if you have pulled over your car. Guys, simple things like this. Somebody wants to talk? Of course. You've been quiet for such a long time, and then now maybe let me catch you. If your mic is off, you owe me coffee. Dr. Ali, you owe me coffee. Just give me a call and you can buy me some coffee later on. Okay, but these are the basic things first. They're the ones who are calling for information. You have the power. Okay, you want to say, first of all, verify triple. Then now you want to say, where are you? Because if she's 5 minutes away, tell her, can I give you some time? It's important for me to sit down with you and give you a full update, and even we can talk about what concerns you have. No, doctor, I can't come in. Okay. Are you driving? Yes, I am. Can you please pull over? Are you on the motorway? I am. I'm on the first lane doing 100 miles. And pull over, Samantha, please. Kindly pull over. Or, are you close to your destination? Do you want to call me back when you are at your destination? These are big safety steps, okay? Now, I would want to give you in detail what has been happening to your mom, but it's important for me to get a good picture about her health or her past history, okay? What complaints did your mother have this morning? My mom had a headache, or my mom was coughing blood. Okay, how long has she been coughing blood for? For the last 3 weeks, okay? And so she came to us. Are you the one who called the ambulance at all? Yes, I am the one who called the ambulance. I wanted to quickly run to work and then come and see her. Okay, so you would like an update. In fact, as I have mentioned before, I would reiterate it twice. As I've mentioned before, we usually do not tell any news over the phone, but I can make an exception for you and just give you an overview of what has been happening, and we need to talk about it in detail when you come. It would be good for you if she says, I can't come in later. You want to make a little bit of a scare by saying, kindly, just if you can postpone some of the activities you have for the afternoon, it is important for us to see you. Why? Because it's a breaking bad news. Maybe the mother is dying. Maybe we found a terminal cancer, or maybe the mother is unconscious. You don't know. Whatever question you get, ask her, please, are you able to postpone the activities for the rest of the day? And now, because there are so many of you and I'm teaching the same thing, I don't want it to become script. So what you can do for yourself is go and change the words. Make your own personal words, okay? Samantha, your mom's situation is on the critical side. Okay, she came in, she had a headache, right? We did our scans and we were very concerned because we saw that some of the vessels in the brain were leaking blood. This is an intracranial hemorrhage. Much easier than saying, your mother has an intracranial hemorrhage. Do you know what this is? Okay, I'll explain to you what an intracranial hemorrhage is. You can't do that in a breaking bad news. You want to explore it and then say, this is what it is. Samantha Jones, you have a cancer or cancerous cells that are inside some of the ducts of the breast. This is known as ductal carcinoma in situ. Then you wait, because every time you give somebody news, you want to keep quiet and let them absorb the news. And I always teach the 4-second rule. You break the news and then you're quiet for 4 seconds. Count them internally. Samantha, are you still there? It's really not my desire to tell you in full details what is going on. I would want you to come in, please. Her situation is critical. Then here comes all the common questions that we hear day in, day out. Is she going to die? What is going to happen? Is this a bad outcome? Is she in a very critical state? What? You can never answer the question about death and how long does somebody have to live. Those are questions you have to learn how to avoid. And how I teach it is I say, her situation, yes, is critical, and our team is taking care of her. We are hoping for a good outcome. Sometimes the outcomes are really not what we expect, okay? But we are equipped for whatever happens. Samantha, it's important for you to come into the hospital, please. Yeah. Here is a big thing. Samantha keeps quiet over the phone. You have to say, Samantha, hello, Samantha, are you still there? Samantha, yes, I'm still here. Samantha, can you please give me the address of where you are? I really don't think you've taken this news too well. I'm really concerned about your condition. Or she starts to hyperventilate. Oh my gosh, what is happening? My mother is going to die. All this. You see why it is so good you told her to pull over? Because if she was driving on the motorway, she could have put other people at risk or even her own self at risk and crashed. That's why you want her to pull over to the side of the street. If she's hyperventilating or she's gone quiet, you want to even say, please give me an address so that we can even send one of our hospital vehicles to come and pick you up and bring you to the hospital. Is there anybody you can call at this time, or do you want us to call somebody for you? Okay, what have I said here? Only break the news if you feel the patient or the family member is in the safe place. Okay, if the patient is not doing well. So now, Who has become the patient? You have two patients now. You have Melissa Jones, who is battling the coughing of the blood, okay? And then now you have her daughter, who is hyperventilating over the phone. Two patients. You have to care for the woman who you broke the bad news for. Please do not drive. Let me send a hospital vehicle to you, or we can even send one of a public vehicle or a taxi to come and pick you up and bring you to the hospital. This is why I usually don't like to release news over the phone, because Samantha, it's much better if we are sitting face to face. That way I can address your concerns and I can also see how you're responding to the news. When you come in, we will go and see your mother, or if you want, you can even have other people or your family members meet you in the hospital, and I can tell you about what is happening in more detail. Can I hold on the phone with you until the taxi comes? Now, 77 of you are going to go say all this in the exam, and this becomes script. It's one of my beautiful keys that I give them in the course. Little bits of IPS that you don't hear anywhere. Where do I get IPS from? You learn IPS, guys. You learn it. You learn it from the business world. You learn it from nurses. If you're in your home country and you're working, sit down with a nurse and buy her coffee and tell her, how will you tell somebody they are dying? Can you give me some good words? You learn it. You learn it by going on YouTube. I tell my doctors, go in and type in Canadian nurses. They're the best. Canadian nurses and breaking bad news. Listen to other people have conversation. That is how now you learn. And then not only getting good notes, but also practicing it with your family members. So, and that's why this exam is 18 stations, because you can fake IPS for 5, 6, 7, 8 stations. By the 10th stations, it's the real doctor. You don't care about the patients. You don't care whether they're here. You don't care about concerns. The real you shows up in the end because you're tired also. So these are things that you have to learn. Learn how to be warm, how to have a warm heart, how to smile at people. Even with the examiner, you walk into the station, don't look like you're begging for points. Hello, examiner. No, leave them. They're a colleague. You don't need them. You need the patient. Go to the patient, smile at the patient. And I really appreciate some of the doctors who are teaching the Plab, who are teaching people the right way to do things. You don't have to be fake, okay? Keep your smile for the patient. Smile at them. If they are able to greet you, greet them. If they are not, well, not. Now with the COVID-19, I would not approve greeting. But even if the patient sends out their hand to greet you, Vane, greet them. Then wash your hands later. How can you do examinations without washing your hands? That's another big thing in this exam. The hand sanitizer is somewhere in the room. You don't look for it because you don't wash your hands on a daily basis when you're doing regular medical care. Look for it before you touch a patient. Say, as you're getting ready, James, let me just clean my hands and then we can proceed. Okay, please learn to be warm to people. Think of this patient as not only just somebody sitting there, but it could be your mother, father, brother, sister. It could be you, right? So you're in a place of privilege to have knowledge. You must listen. Absolutely, you must listen. I'm wondering if my phone is dead. No, okay. You're so lucky. This was supposed to be 1 hour, but let's keep going. Psychiatry is another environment. So how I have catered this role of the FY2 is to talk with settings, because it's important for you to know the setting. There is adult psychiatry and there's child psychiatry, guys. You have to know child psychiatry. Why? It's a big thing in this country. You just can't go and learn, what are the cases for the WAST for psychiatry? There are only 2 of them. And in the Plab, there are only 3. No. Look at all these cases that have been listed at that wonderful website that I told you about. Now, I'm going to focus on child psychiatry because adult psychiatry, you can go read by yourself, MDD. Do me a favor. Today, before you sleep, just go and type in common psychiatric diseases in the NHS. All the Plab cases are right there, all of them. and the NHS information on what to do for each case. Get good knowledge, guys. Now, in the CAP, the Child and Adolescent Psychiatry, doctors work with children and young people up to the age of 18 and their families. The only person who you do not need a companion or guardian is somebody who is a minor asking for sexual help. That one, you can have a one-to-one conversation. But a 16-year-old who has come to see us in the emergency room, I usually say, where's your mom? Where's your dad? Do you have a guardian at all? How old are you? I'm only 14. You came by yourself. You've been waiting in the emergency room to speak to me? Yeah. It's important because you're a minor. Some decisions need to be made by your mom. So at some point, we need to talk to your mom about this. In fact, I can't do anything until I have permission from your mom. But let's talk about what's going on. The GP saying you're losing weight? Yes, I'm losing weight. So talk to them. Then when it comes to management, you say, I'm going to give you a bit of what we can do for you, especially some of the lab work that we may need to check and some of the referrals we need to do. A referral is a doctor who is more specialized in whatever condition you have. But I want your parents here so that we can get their permission. Please, if you have a child and the parent in the room, please say hello to both of them. Hello, Samantha. Is this your daughter, Mary? Yes. Okay, so Mary, you're our patient today. Yeah. How old are you? 14. It's really good that your mother is here because I will ask you some questions. It's important for her to be in the room, but I must give you a heads up. There are some questions I will ask that may seem a bit embarrassing, okay? So just bear with me in these questions. So you talk, and then you tell Samantha, you tell Mary, now I have some of the personal questions that I need to ask you. Please do not feel embarrassed about them. It's about sexual health. Are you sexually active? But you see what you've done? You've not put a 14-year-old in front of her mother and then you're just asking, are you sexually active? Give her a heads up in the beginning. Now, what if it's a 19-year-old, she's above the age of 18, okay? What if it's a 19-year-old and the mother is there? You go in and you say to her, Samantha, you're my patient, you're 19 years old, and your mother is here for the visit because you're an adult. I have to get permission from you for your mother to be present during this visit. If at any point during the visit you would want her to excuse us, please let me know. Why? You have to get permission. She's an adult. You just can't start talking and the room is 3, 4, 5 people. That's another thing. Even for us in the emergency, and we go in and you find it's the whole African village from Kenya there. You can't just say, Samantha Jones, you just say, hello everybody. My name is Dr. X. I'm looking for Samantha Jones. My name is Samantha. Hi, Samantha. I'm your doctor for today. My name is Dr. Lianne. I work in the emergency room. I can see you have such a great support here. Are these your family members? Yes. Of course, there are other, examinees and simulators who are practicing for the Plab. But they're in the room, guys. You cannot just ignore them. You can't. You want to say to her, are you comfortable with having your family members, or are you comfortable with having these people in the room? Why? Because for you, this is not an exam. For you, this is the hospital setting. And they say it on the GMC website, they say they are evaluating how you would work like an NHS doctor. So you have to check all these things even before you start. Anyway, let's go back to this thing. Child and adolescent psychiatry. They treat a range of mental health problems and conditions, including autism. You have to go read about autism spectrum, okay? Depression, anxiety in young children. Wow. And a young child who's coming in anxious, the first thing I'm thinking is non-accidental abuse. Why would a little boy be anxious? Why would he be screaming in the night? Who does he live with? Okay, what is his bedtime routine? Has he gone visiting with anybody? Are there new people who have come to spend the night in the home? Is he more afraid with certain family members? talk to him about it. Substance misuse. Oh, doctor, I found marijuana in my child's closet. You need to go and think of these cases. Eating disorders. Did they say anorexia here? No, because it's very hard for you to diagnose anorexia in 8 minutes. Anorexia needs to be diagnosed by a psychiatrist. We need to find out what are the influences about it. And just because they are losing weight and their BMI is low, it doesn't mean they are anorexic. They have an imbalance of what they are eating and what they are putting out. That's where the imbalance is. It could be caused by different things. Let's investigate. The blood sugar, guys, I keep saying, young people losing weight, you have to check a blood sugar. Okay, the rest of the page in this website by the NHS talks about a self-harm patient. You have to know how to deal with self-harm. Alcoholic patients, drug abuse, somebody who wants to quit drugs. Okay, here's another one. ADHD, go polish up on that. Autism, learning disability. My child is 2 years old, my child is 4 years old and they cannot read, doctor. Delayed reading developed. Are you seeing how many delays we're having? Go and research all the delays you can find and I'll name them again. We started with delayed walking. Then there's delayed walking can be because of an injury. Don't forget medical problems. Okay, delayed speech can be because of hearing problems. Okay, you have to ask questions like, are you noticing any changes in the size of the jaw? Does your child's jaw look a little bit smaller or larger? Is their tongue really large? Are they able, when they close their mouth, can your child close their mouth fully and keep the tongue inside the mouth? When your child is talking, do they sound like they have a lisp or a heavy tongue? When you bring your child in, I'll need to evaluate and see if they're tongue-tied, if they have a cleft palate. You just can't say it's normal. Oh, the death to that script. Why? It's ruining good doctors. And even the rates I'm seeing of passing are a little bit higher with people who've never gone to had any training with this teacher, this academy, this other academy. These guys are coming in from their country, going for the Plab and getting a 160. Why? Their minds are clean, not programmed to answer questions in a certain way. Remove you are much better. You are much even better than talking before you talked to me. Go back to your normal language of medicine. Go back to real medical language, please. Okay, delays, delayed walking, delayed talking. They are peeing in the bed. Okay, so they delayed continence. Okay, a young girl who's peeing in the bed, don't you know that there may be a problem with the signals from the brain to the bladder and developed nervous symptoms? She could be scared in the middle of the night. She could be constipated, because constipation can also cause incontinence. And the number one big thing, she could be diabetic also. She's peeing only at night or throughout the day also. Big questions, all right? Another delay, what did we say? I'll have to remember. Delay in puberty. My child is 17 years old, doctor. She's not had her monthly period. Oh, there are different reasons why you can miss a period at 17. First of all, is she pregnant? Get out of here. Easy things fast, okay? So is she pregnant, okay? Even you as her mother, when did you start your cycle? Were you delayed also? It could be a genetic thing. Another thing is her nutrition. Is she malnourished? You know, all of us in Kenya are put into exercise programs for running because we are told, make sure you go and run the marathon. So all of us are delayed because we are in hardcore exercise from the age of 10 to 18. Running in the hills and the mountains, running. Everybody's delayed. Exercise, rigorous stress, lifestyle of poverty, you're not having good nutrition. It will delay. Think about the normal things first, okay? What was the other delay that I said? Delay in reading. My child is not reading. Maybe your child can't see. Oh, maybe there's they can't hear the words. Easy things, please, okay? Next one, Autism and learning disabilities. Some of you are saying your child is autistic. How do you say a child is autistic in 8 minutes? Impossible. We have to check their structure, their behavior in different settings. At home, you and your diary writing all their symptoms. They come here into our behavioral units and they sit down with a therapist, a play therapist. We are recording, we are looking at them. We even talk to the teachers at school in that setting. And then in about 5 to 6 months is when you can give autism a diagnosis. Be careful. Tick disorders. My child is just ticking, or having a tick in their shoulder or whatever. Emotional and behavioral problems, disruption, depression, anxiety, OCD, attachment disorder. My child never wants me. My child is 3 years old. Every time I go to work, they are crying. Of course, I'd rule out NAI. So much. Good. At least we are almost done. This doctor hasn't yet called me. Good. Examination and skills. I told you in the beginning the 3-2-3 method. Okay. 3 minutes for data. Please. For everything that's good, collect data, even though it's a few questions. Okay. Data collection for 3 minutes, examination maximum of 2 minutes, and management for 3 minutes. Your responsibility to get skills in the areas where they are deficient. Focus on your weak points. Please research and be prepared. When I teach my doctors, I tell them to be organized. Don't just spend time reading bundles. Oh, you did 36 bundles. No. 1 hour YouTube videos, another hour do mocks with one doctor, another hour catch a free mock, another hour. A good student has many teachers. I'm not the only one teaching the Plab. Find good teachers. They are there. Some of them have even been my students. They're doing a good job. Find them. Gain your knowledge. You have to be prepared. I picked this one from our deanery, Oxford Deanery, for the following procedures and skills that are necessary for an FY2 to know. Now, I want you to go and compare this list with whatever you've had, maybe has been tested in the WAST or in the OSCEs or in the Plab too. You should be able to do a catheterization, Foley-cath, cannulation, blood cultures. Okay. Do you know what tubes we use and bottles we use for blood cultures? Do you know what is done when you get a blood culture? Do you know why one tube has to be aerobic and another one anaerobic? You owe me coffee because you're interrupting the course. Yeah? Yeah. There's a blue cup tube and a red cup tube with blood cultures. You have to know which tube needs to have, did I say anorexic? No, anaerobic, I mean. There's a tube that has to have anaerobic because it's going to grow all the bacteria that are anaerobic. There's a tube with a red cup that is for aerobic bacteria. You have to research, okay? I think I'm going to put up a video on our Facebook page because that's why I like to put all the future cases, okay? How do you give an IM? How do you give a subcutaneous IM injection? You think in the bum you just go anywhere? You're going to hit the sciatic. You're going to give paralysis. Upper right quadrant, few inches from the ASIS bone. You have to really go and review because they can bring a nice, beautiful station. James, the medical student, wants to learn how to do IM injections. Just you have to put the needle in, aspirate to make sure you're not in a blood vessel, guys. Come on, study, okay? Next. We don't give cytotoxic medications as FY2s. Arterial blood gas sampling. I have that video on my Facebook also. O2 therapy, nasal specifics. Here, nebulizer therapy. NG tube, I am so surprised. Oi, GMC, you guys don't have an NG tube station yet? This is such a common thing for FY2s to do in emergency. If I am in the emergency room working and a patient comes in, abdomen is distended, and I call my seniors and the patient doesn't have an NG tube, oh my gosh. They're going to shoot me. Okay, keep this list. This whole session has been recorded, so I'll leave it on YouTube so that you can go and listen to it again. Removal of chest strings, straightforward suturing is another one I'm surprised they haven't brought in. At least learning how to do interrupted sutures, you have to look at the videos, okay? So be over prepared. Lumbar puncture we don't do. This is Oxford Deanery, so I don't know what they're doing in that deanery teaching people to do a lumbar puncture. Lumbar puncture we do not do. Speculum we do. Joint aspiration, you have to really check it with your the policy in the hospital. And that's that brings me now back to the initial sad case I gave you, where the doctor told the FY2 to go and give medications to a patient, and they had an adverse reaction and they ended up on dialysis. If my consultant tells me something, I have to go and look it up. And if I'm concerned that it's the wrong treatment, I go to my registrar and I say, hey, Dr. X told me to go and give this medication. Do you want to just cross-check it with me? Have we caught our consultants in mistakes? Yes. Have we told them? And they are so happy when we do because we are thinking. Sometimes it's even a trap. They tell you, can you go and give this medicine? And you go and you're like, we don't even give this as an FY2. Thank you. I just wanted to make sure that you know as an FY2 you can't do that. Please don't be the doctor who just takes information. What was in your exam today? Oh, blah, 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 blah. Okay, what did you give antibiotics? No, I will not give antibiotics. You cannot do that as a doctor. You're too powerful. You're too powerful to be a robot. People will die if you're a robot. Please, please, please. If I told you you've only reached you're joining me now and that's the information you're getting, you owe it to the privilege of being a physician to always keep ahead in learning, knowledge, and understanding. And of course, being humble enough to know that people's lives are in your hands. You need wisdom for every day and for every station. Even for my exam, literally outside every door, I was saying a prayer. I was saying, God, help me to understand what these people are saying. Sometimes their language is so difficult. Okay, and now why would you fake that you can understand the patient's accent? Some of them are being told to act like you have a very thick accent. Hello, my name is Patricia Smith, and I come from and there you are. I can't understand. Okay, Patricia, do you have any symptoms? I don't know. You have to say, I'm really sorry, Patricia. I'm having a hard time understanding you. Do you mind if I move a bit closer? Can you speak a little bit slower and a little bit louder for me so I can understand? That way I can know what is going on and so I can come up with the correct plan. Then the patient changes. Hello, I'm Patricia Smith. Now you're going to sit there in the exam and somebody has a big accent and you don't tell them, are you able to slow down a little bit? It's not ruining IPS when you're honest. If you can't understand them, tell them, please, can you repeat for me, okay? Now, final points. Every single part of this examination in the NHS, in the Plab, in the WAST, first impression, guys, it's an unstated thing. You will be judged with first impressions. Your beginning has to be immaculate. My name is Dr. X. I am one of the junior doctors in the emergency room. You have to be clear. Practice it. You can't just say I'm one of the doctors. What if they think you're a consultant? They'll say you're trying to pretend to be a doctor that you're not. You have to say you are a junior or you're an FY2. You just can't say I'm a doctor. You could be any doctor, okay? Next, with the patient, okay, you have to read the verbal and the non-verbal language, and you have to respond to both. So the patient is talking to you in two different ways. They're saying some things and their body is doing some things. Are you responding to both? Samantha, how are you doing? I'm fine. You're telling me you're fine, but I can see you're holding your hand, your head in your hand. Everything doesn't seem right to me. Can we talk about it? So you've addressed the verbal and the non-verbal also. Okay, manage your time properly. the end is actually better than the beginning. So you have to try and finish well. I tell my doctors, you don't have to finish, but try and finish well. If the bell rings and says, move on to the next station, absolutely stop. You don't want the examiner to think that, oh, you're just trying to steal extra points and everybody else is moving on, and there you are saying, I want to do this. No, stop, say thank you, and walk out. Okay, the last, I told you here, 3 for data collection, 2 for your physical exam, and 3 for management. Remember the ABCDEFGH I taught ahead. If you're confused about management, you always have to have a plan with the differentials. And remember that everything the patient says is gold. There is a reason why they are telling you X and why they're telling you Y. Sometimes the patient wants to help you. Don't feel bad if the examiner tells you, examinee, can you read the question? Thank you. Why? Because this examiner is helping you. You'd rather an examiner who is trying to redirect you back onto the proper way than an examiner who is just going to keep quiet and watch you ask useless things. I want to be told, please, can you read the question? Thank you. I'd forgotten the patient's name. Let me just read the question. And you say, thank you. And then you tell the patient, excuse me, let me just go back to the medical notes. You read the note again, pam, 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 pam. You put the note back down and then you proceed. When the examiner tells you to read the question, does it mean you failed the station? No, they're helping. You can finish a station and fail. You cannot finish and you can still pass. Okay, so finishing is not the big thing, it's the quality, right? So I hope I've helped you today. Let me see what I know you're so many of you. Let me see if you have any questions right now. And then we can take it from there, yeah? It was a good session. I'm really sorry I took a lot of time.